Madam Chair, we are now live on YouTube.
Good morning, everyone. It is 9:04 a.m. Welcome to the March 24th, 2022 meeting of the Public Employees Benefits Program Board. PEB staff, would you please call the roll?
Laura Freed.
Here.
Linda Fox is excused. Betsy Iao.
Here.
Jim Barnes. Jim Barnes, are you here?
Jim wasn't was here or there.
April Corin.
Here.
Michelle Kelly. Leslie Biddleston.
Here.
Jennifer McClendon.
Here.
Tom Verducci.
Here.
Janelle Woodward.
Here.
Okay, and just to check again, do we have Michelle Kelly?
Here, can you hear me?
Thank you. We have a quorum.
Yes, okay.
Yes, this is Jim Barnes. I'm here too.
Okay, thank you. And I'd like to extend a warm welcome to newest member, Janelle Woodward. Welcome to the board. The rates meeting is a heck of a first meeting to join us at. So congratulations on your appointment. And it's always interesting to be a PEB board member. With that, I will move to agenda item 2, public comment. As per the agenda, I'm going to limit each comment to 3 minutes per person. And if we get a whole bunch of public comment, I'm going to let you guys know right now that because we have rates and some other rather large items to get through, I'm going to limit public comment to 1 hour in total. And there is a second public comment period at the end. So with that, I will turn it over to PEB staff.
Okay. As a reminder, Zoom is used for public comment only. This meeting is for live streaming on YouTube. And if you want to just listen to the PEB board meeting, the YouTube link is located on the agenda. For those who have joined for public comment, your name or last 4 digits of the phone number will be announced and you'll be advised you have been unmuted. As a reminder for those on the phone, please press *6 to unmute. Please slowly state and spell out your name for the record and proceed with your comments. Okay. The person with the last name Gladstone, you have been unmuted. You have permission to talk.
Good morning, board members, and thank you for the opportunity to speak today. My name is Jeremy Gladstone, Jeremey, Gladstone, Gladstone. I am a PEB member under the Consumer Driven Health Plan. I'm here today to voice my concerns regarding PEB's subrogation process. This process, which results in the delayed payment of members' claims, is an unnecessary burden on state employees. While I support subrogation of claims, I feel that the process should be restructured to lessen the burden on PEB members. To lessen the burden, I recommend that PEB should do the following. 1, process the claim first and then subrogate the claim. 2, PEB's claim administrator should review patient history to determine if the procedure is part of an ongoing treatment or the result of treatment for a chronic illness or condition before referring to claims PEB's subrogation attorneys. 3, the process should be applied in a fair and consistent manner. On more than one occasion, this process has paid the lower cost claim related to a procedure and denied the higher cost claim despite both being related to the same issue. I respectfully request that the board give direction to PEB staff to revise the current subrogation process related to this program, and I appreciate the board's time on this matter. Thank you.
Thank you for your comments. The person with the last name Johnson, you have been unmuted. You have permission to talk.
Good morning, ladies and gentlemen. My name is Jenny Johnson. I have worked for the state of Nevada for 20 years. I'm just here to support the rescinding of the additional fees that were voted on for unvaccinated state employees. I think it's unfair and a kind of a slippery slope of when do we start charging people who are obese, and when do we start people who are, have other smoking. And so I support rescinding that on today's meeting. Thank you.
Person with the last name Irvin, you have permission to speak.
Good morning. Kent Irvin, ERVIN, State President of the Nevada Faculty Alliance. Today, Nevada PEB is literally adding pregnancy to its list of items requiring pre-authorization. That's in the master plan document for the high deductible health plan. It's hidden in the PEB's board's consent agenda 4.8 on page 103 out of 975. The full list of services requiring pre-certification or prior authorization starts on page 101 and continues through the new paragraph on pregnancy on page 103. The inclusion in the pre-authorization pre-certification list means that PEB's benefits administrator, not a doctor or not your doctor, can deny related claims per a new delivery of services section, which is on page 99 of 975. These are all items where an administrator, not your doctor or a medical team, can decide whether healthcare services should be provided. Sure, the state employee can choose to pay themselves, and they can also go into medical bankruptcy as collections mount up. The pre-authorization for pregnancy, that language is already in the master plan documents for the new low deductible plan, but those master plan documents were never approved by the board. They weren't on the agenda a year ago. These master plan documents are the policy of PEB for determining benefits provided in each plan, and they should be carefully and fully vetted by the full board every year, any changes, any new items. Thank you.
Okay, person with the last name Burgeon, you have permission to speak. Please unmute your mic. Person with the last name Burgeon, please unmute your mic if you wish to make a public comment.
No comment.
Okay, the caller with the last four 1715, please press *6. You have been unmuted. Caller with the last four 1715, please press *6. You have been unmuted if you wish to make public comment.
Hi, my name is Brad. I just wanted to support the rescinding of the surcharges for the unvaccinated people. I think it's pretty discriminatory to do that to them. Everybody's personal health is their own choice, and we shouldn't be punished for that. And I would like to just express my concerns about that, because as the previous caller said, it is a slippery slope. And I would really like to see those surcharges be rescinded. Thank you for your time.
This is
Okay.
Laura Great. I'm sorry, PEB staff. This is Laura Great. Callers, would you please state your full name for the record? And if it's a difficult to spell name, go ahead and spell it. So for the benefit of the court reporter and the staff. Thank you.
Okay, caller with the last four phone number 4114. Please press *6. You have permission to talk. Caller with 4114. Please press *6. If you want to make public comment. Okay, we'll go back to you later. Okay, the person with the last name Cortez, you have permission to talk. Person with the last name Cortez, please unmute your mic. You have permission to speak. Person with the last name Druger, you have been unmuted. Please make public comment.
Good morning. Can you hear me?
Yes, we can.
Great, thank you. Jenny Druger, and I also would like to support the rescinding of those charges for the unvaccinated. Thank you for your time.
Caller with the last four 9532, you have been unmuted. Please press *6 if you would like to make public comment. Caller with the last four 9532, please press *6 if you wish to make public comment. Call in person with the name Brad, please unmute your mic. You have permission to speak. Brad, are you able to hear us okay? Oh, Brad messaged the chat. He was the one who called on the phone earlier. Okay. If for those who are still in here before I made public comment, please leave the meeting. You could just watch it on the YouTube link. We have a few more. Person with the last name Malath, you have permission to speak. Please unmute your mic.
Good morning. For the record, Brooke Malath. Once again, I must call out the inaction of the executive officer to provide remedies on the master plan's exclusions that are discriminatory towards transgender persons. Under the Affordable Care Act and as interpreted by the Nevada Insurance Commissioner in 2015, the denial, exclusion, or limitation of benefits relating to the coverage of medically necessary healthcare services on the basis of sex as it relates to gender identity or expression is prohibited. The Supreme Court of the United States ruling under Bostock clarifies employment law under Title VII that sex discrimination includes discrimination on the basis of sexual orientation or gender identity. I have been bringing this matter to the board's attention for over 1 year, and there is yet to be any action taken. Let's be very, very clear. Excluding transgender-related health care is discriminatory. Singling out transgender health care for exclusion is a form of discrimination, just as it would be sex discrimination if a plan were to exclude all coverage for gynecological care, and it would be a disability discrimination if a plan were to exclude all treatments for HIV. Both sex and disability discrimination when a plan carves out and excludes medically necessary care simply because it is for the purpose of treating gender dysphoria is discriminatory. Transgender employees pay the same premiums as other employees, yet receive unequal benefits in return. Employees who are transgender or who have transgender dependents subsidize the health care of their co-workers, yet are denied doctor-recommended care for themselves and their families. Transgender-related care is medically necessary, and there is no legitimate non-discriminatory basis to single out transgender care for exclusion. It is precisely for that reason that insurance companies developed explicit exclusions for transgender-related care, because it would otherwise fall under standard surgical, mental health, physician, diagnostic, or pharmaceutical benefits. Transgender care is neither experimental nor is it cosmetic. And existing plan definitions of medical necessity are sufficient to ensure that only medically necessary services are provided. I urge this board to make this a priority for the executive officer to address immediately so that those in need can access the medical interventions that they need to mitigate the symptoms of gender dysphoria. Every day lost is another day of agony and anxiety for people with specific needs. Every day lost is another day closer to the board having legal action taken that will force the plan to comply and add significant financial penalties as well. The supposed pennies that you are saving today will cost thousands of dollars in the future if you continue to delay. Please take action. Thank you for your time.
Okay, the caller with the phone number ending with 0271, please press *6. You have permission to speak.
Hello?
Hello, we can hear you.
Okay. Yeah, my name's Joel Tyning, Joeltyning. I just wanted to call in support for agenda item number 6 for repealing the surcharge against those that didn't take the COVID-19 vaccine. I just want to say, from the beginning, this was clear discrimination. There's many ways it can be labeled as discrimination. So the biggest one, and one that's actually protected by law, is religious discrimination. So those of us that chose not to take the vaccine due to our religious preference, that surcharge would then become religious discrimination. It's just punitive punishment for us not jumping on that political bandwagon. But now that all the COVID-19 stuff's going away just in time for the election, this is the perfect time to get rid of the surcharge, because and it also behooves PEBP to get rid of that surcharge as well, because I know I'm not the only one that was planning on dropping my health insurance permanently. July 1st, I was going to just drop my PEBP coverage, which then would hurt PEB. If just 1,000 of us dropped our coverage, PEB would lose over $3 million a year. So it's probably not the best idea to keep that surcharge. Also, it's unfair charging to keep that surcharge, because We don't charge extra for people that smoke. We don't charge Roman Catholics for not using condoms. We don't charge Black people because they're the only ones that can get sickle cell anemia. So yeah, now's the time to get rid of that surcharge because I think a few other commenters use the word slippery slope. I think that's a perfect way to describe it. It is a slippery slope, and it's going to cause quite a bit of problems if that surcharge stays in effect. So it's a brilliant thing to go ahead and rescind that. Thank you so much for the opportunity to comment, and have a great day.
Okay, person with the last name Slope, you have permission to speak. Please unmute your microphone. Person with the last name Slobe, you have been unmuted. Okay, we'll go to the next one. Person with the last name McDonald, you have permission to speak. Please unmute your mic. Caller with the last four, 7862, you have permission to speak. Please press *6 to unmute your phone.
Good morning, esteemed members of the board. My name is Will Dawson. I'm a retired detective who served the state of Nevada and a board member of the Nevada Police Union. I'm here today to advocate on behalf of our members and their brethren in state service regarding the proposed surcharge for unvaccinated employees. As you're aware, the state of Nevada has a retention problem with their employees. Tragically, this turnover issue is even worse among our public safety personnel and the supporting staff that make their jobs possible. As employees who are often paid 30 to 50% below the wages offered by competitive employers, there's little enough incentive for employees to remain in state service. Taking more of their hard-earned money to pay for the effects of the terrible disease which was unleashed on us in the past 2 years is going to make retaining employees even more difficult and result in unnecessary losses to our public safety community. In a time of exponential cost growth due to the skyrocketing costs of housing, food, and energy, the budgets of state employees are already strained, just like the budgets of our private sector brothers and sisters. Unfortunately, however, state employees cannot readily negotiate pay increases to offset these increased costs like the private sector can. Our employees must rely upon the legislature, who has failed to adequately address the cost of living increases necessary to remain competitive in the workplace for decades. The only other option is to leave state employment, something that has been happening at an ever-increasing rate to the detriment of our state. Due to the non-competitive pay of state jobs, often, one of the saving graces was the insurance package, which has traditionally been reasonably affordable for most employees. This surcharge will destroy that incentive. Charging a single parent of 3 children an extra $580 a month because they choose not to receive a medical intervention, whose side effects can include permanent disability and death, is a travesty. You are forcing employees to choose between a job and possible harm to their health as well as the health of their children. Something that as a parent, I can assure you, is only going to have one reasonable answer, especially for our lowest paid employees, for whom that amount would be more than 25% of their take-home pay. Instead of making current and former employees bear the undue burden of paying for unfunded mandates, there are other options you can pursue. The choice is yours to make, but I assure you the decision to discriminate against employees and retirees who are on a fixed income could be very costly to your members as well as the organization due to the costs which will ensue. Thank you for your time and this opportunity to speak on behalf of our members.
Okay, person with the last name Manakuchi, you have permission to speak. Please unmute your microphone.
Hello, can you hear me?
Yes, I can.
Hi. I work for NDP, and I don't think that it's a good idea to increase our health benefits at this time. The state of Nevada has not had a comp and class study since Governor Gwynn was in office. And right now, the administrative class, which I'm in, I'm basically hardly making it paycheck to paycheck. And this will just cause more of a hardship on all of these families who are struggling during these times and through this recession. And you just did a huge, you just raised our fees last year. So I don't understand why this is a yearly thing. Our paychecks aren't going up, our wages aren't going up, and our wages haven't gone up in over 20 years. So I think that it's very unfair that you're putting this on the backs of these people who are barely making it, some of us are working 2 and 3 jobs to make ends meet. And I'm begging you, please do not do this. That's all I have.
Ms. Benacucci, could you state your full name for the record?
My name is Paige Menacucci.
Got it. Thank you.
MENICUCCI.
Thank you.
Okay, the person with the last name Martinez-Boyd, you have permission to speak. Please unmute your mic. Person with the last name Martinez, please unmute your mic. You have permission to speak. Caller with the last 4 phone number 4404, please press *6 to unmute your phone. You have permission to speak.
Good morning. Can you hear me?
Yes, we can.
Good morning, respected board members. This is Kevin Ramp, a labor representative with AFSCME, Local 4041. I'm a labor representative for state employees for numerous bargaining units, and ultimately the state employees throughout the state that are in the non-bargaining units. We have serious concerns in regards to the increases in the PEB premium rates. We ask the board members to respectfully look at it due to the economic concerns and inflation and other costs to state employees who are continuously putting the burden on them. We seriously ask the board to reconsider and to look at other options instead of putting it on the backs of state employees. State employees cannot continuously afford these higher premiums with lower benefits. At the end of the day, it comes down to the board having to make these tough decisions to be able to find the funds somewhere else. There are some excessive reserves to look at. We need to take a look at this and again, not put this on state employees. We respectfully request this to be done today. Again, this is not something the state employees could afford. We appreciate your time. Have a great day.
Caller with the last 4 7832, please press *6. Your phone has been unmuted.
Yes, thank you, and good morning, Chair Freed and fellow board members. My name for the record is Terry Laird, last name Laird. I'm the Executive Director of the Retired Public Employees of Nevada, where we represent mostly retired public employees, although we do have quite a few members who are still working. Created in 1976, RPEN lobbies to protect the pension and health care benefits all public employees earn while working and deserve once they've retired. We currently have nearly 8,000 dues-paying members, and we are a nonprofit, nonpartisan, membership-based 501c4 organization. Our PEN works alongside other public employee groups, and as you'll hear from them today, I can tell you we agree with everything they'll talk about, especially concerning the massive problems PEB is experiencing with its enrollment and eligibility system that has impacted many active participants as well as retirees. I've spoken with several of our members who've called us with their issues, and when trying to resolve the problem on their own, ran into long delays from PEB's call center, who, as you will hear from Executive Officer Rich, is woefully understaffed. In her own words to us, the current problems with the enrollment and eligibility system is a complete nightmare. All state employees and retirees in PEB and the Medicare exchange deserve better. The staff shortages are inexcusable, and it's something that's been noted many times, not just for PEB, but for all state agencies. It's time for the situation to be rectified, and we are hopeful to once again highlight this problem relating to recruitment and, more importantly, retention at the 2023 legislative session. The state needs to have the ability to hire good employees, pay them a livable wage, and then keep them with good and, more importantly, reliable benefits. We thank Ms. Rich for keeping our advocacy groups informed and for the assistance she and her staff were able to offer our members who came to us for help and who, when we brought their plight to Ms. Rich, she got the problem solved in a timely manner. But our greatest concern is those participants who are impacted by the problems with enrollment and eligibility and may not even be aware of it. So we urge action to be taken as soon as possible to move away from the current vendor and back to the previous system that worked. Finally, our PEN is happy to hear, too, that the proposed COVID surcharge of $55 a month for unvaccinated participants and $175 a month for each dependent over 18 is possibly going away. We have testified several times against the surcharge, which represented yet another financial impact to state employees who didn't need the additional burden. I thank you for the time to speak and add our thanks to the board for the work you do for state employees and retirees.
Caller with the last four, phone number 4114. Please press *6 to unmute your phone. If you wish to make public comment. Caller with the last four, phone number 6787. Please press *6. You have permission to speak if you want to make public comment.
Good morning. My name is Sean Gallagher. Last name is Gallagher. I'm the president of the Nevada State Law Enforcement Officers Association. I'm very grateful for the opportunity to speak to the board today in regards to PEB and what many of our members perceive to be a lot of its failing programs, up to and including even just the online portal and the ability for members to even access and take advantage of even their voluntary benefits. We have members who here in late March are unable to even get an ID card, an insurance ID card, if that highlights some of the problems with the PEB program. NSLEOA would also be in support of rescinding the surcharges that are being considered for unvaccinated individuals. We believe that's a pretty outrageous and shameful way to connect with employees among all the other problems that PEB, frankly, that PEB does have. And we would definitely support rescinding those surcharges. History is going to come full circle, and I don't think that history is going to be kind to events like that, where employees are being coerced into doing something, especially when the state of Nevada has such a hard time retaining employees and being a competitive public employer. Thank you very much for your time.
Okay, caller with the last four, phone number 7101. Please press *6. Your phone has been unmuted if you wish to make public comment.
Hi, my name's Janie Phillips, and I just want to support the rescinding of the surcharges for the unvaccinated individuals. As a single mother of 2 small kids, there's no way that I would be able to afford it. So I would end up having to get a second job or quit and find a different insurance. Thank you.
Caller with the last 4, phone number 7832. Please press *6 to unmute your phone if you wish to make public comment.
Yeah, this is Terry Laird. I've already spoken. Thank you.
Okay, thank you. I'm going to go through a couple that I tried to do earlier. So just real quick, because still about 12 in the attendees room. Caller with the last name Slobe, please unmute your mic. You have permission to speak if you want to make public comment. The person with the last name Martinez Boyd, please unmute your mic. You have permission to speak if you want to make public comment.
Hello, and thank you for your time and patience in listening to us today. I am a state employee and I'm a member of ASME Local 4041, and I just ask that you guys vote no on any rate increase for us state employees who are making a sacrifice to better our community. We continue to see our health insurance rates, increase, and we're seeing those services cut every year, which impacts, our family and our ability to be able to provide and also take care of our loved ones. We're paying more for less, and it just continues to spiral, out of control. So we just ask that you guys would be mindful of this as we continue to stay dedicated to what we're doing and protecting and serving our community. Thank you.
Person with the last name Cortez, can you please unmute your mic if you wish to make public comment? Person with the last name Druger, please unmute your mic. You have permission to speak if you want to make public comment.
Spoke earlier, I'm sorry.
It's okay. Thank you. And person with the last name Fulton, can you please unmute your mic if you wish to make public comment? Okay. I'm going to try Cortez again. They just messaged the chat. Person with the last name Cortez, can you try it again? You have permission to speak.
Hello, can you hear me?
Yes, we can. Sorry for all that.
Thank you. My name is Carmen Cortez. I am a state employee and member of ASME Local 4041. I ask you to vote no on any rates to increase the state employee health insurance. PEP continue to increase health insurance rates and continue while cutting services. For example, PEB stopped covering some medication this year, and now I have to pay in full. I also have to look for different places for labs that will have a lower cost because PEB has changed those services too. Thank you for your time and for your consideration.
Okay, that's more or less the list. If anyone experienced any technical issues and didn't get a chance to speak during public comment, there will be another session towards the end of the board meeting. And those who are still hanging out as an attendees, please drop off and watch the YouTube stream instead. And if you wish to make a public comment, please rejoin as an attendee. Madam Chair, that concludes public comment.
Thank you. All right, with that, we will move on to agenda item 3, PEB board disclosures for board meeting agenda items. I will turn it over to Chief Deputy Attorney General Michelle Bray.
Thank you, Madam Chair. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for PEB benefits pursuant to NRS 281A.420. On behalf of those board members who are eligible for PEB benefits or whose families are eligible, I offer this disclosure that they will be voting on these matters that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEB benefits. And at this time, I'd invite any other member that has a potential disclosure to make that now. Thank you.
Okay, hearing no disclosures, we'll move on to agenda item 4. This is, as you know, board members, a whole series of consent items, a bunch of various reports. I trust you've all reviewed. As per usual, is there any one of these sub items in agenda item 4 that anybody wishes to pull for discussion?
Hi, this
for
is
ALO, yeah.
I'd like to pull 4.6, the Clifton Larson Allen audited financial statements.
Okay. Anyone else? Okay, hearing none, I will accept a motion to.
Hello?
Oh, Ms. Kelly, go ahead. We can't hear you. You're muted somehow.
Can you hear me now?
Yes.
Okay. Apparently I have to hold my hand on it. Okay. Can I pull 4.8, the master plan documents, please?
4.8 master plans. Okay.
Thank you.
Anybody else? Okay. Hearing none, I will accept a motion to accept all of the items on the consent agenda except for 4.6 and 4.8.
This is Leslie, so moved.
Thank you. Do I have a second?
I'll second.
Okay, thank you. All in favor signify by saying aye or hold up your hand or your little box.
Aye.
Aye.
Aye. Any opposed, say nay. Okay, motion carries. With that, we'll go to item 4.6.
Hi, yes, this is Betsy Aiello, and I would like to have staff address the information. It was on page 2 of the report that there was some missing GASB requirements, including schedules and management discussion. I'm going to just go through the things because maybe it can all run together. I also wanted to understand the sections where they did identify deficiencies, because some of the deficiencies reported were in fairly high millions of dollar level. And so I'm trying to understand how that could occur and not be identified prior to an audit, and what impact that might have on PEB itself. And I think the last thing was, and I know I brought it up last year at this time, but I noted that the retiree report continues to have an increasing loss position that's going higher. So the fact that we were missing some schedules and management discussion, the fact that there were 3, I believe, reports that had identified financial issues into the millions, and then the retiree loss position.
This is Carrie Eaton for the record. For these GASB schedules, I may have to kick that over to Clifton Larson because I'm not quite sure on that one. The deficiencies, is there a specific one or some that you'd like discussed? Because there are a few, and I can explain them all, or just an overview, because these are basically adjustments made to entries that were posted to the state financial work papers, but they all have like an explanation.
Let me get, if Clifton Larson can talk about the GASB, I'm going to get to that part of the report, and I'll let you, because I hadn't scrolled all the way down into my agenda yet that far, and I will bring it up, but I know that there was some pretty high level ones, so I'll get back to you.
Okay.
Hi, hi, Carrie. This is Allison Slife with CLA. I'm the principal that led the audit efforts this year, and then I'm joined by Dylan Garrison, who is the manager who also worked through the audit. So I can address the item that was asked about within our audit opinion that talked about what was omitted. So I think the primary one that you're calling out is the management discussion and analysis section. So that is a section that for a lot of kind of full government financial statements usually is included, which is an unaudited section. We do typically, on a government that does present those, we do review it for consistency, but it's a lot of narratives that kind of talks about changes year over year, and then talks about future economic or changes that are kind of happening in the subsequent fiscal year. So that is something that is optional for governments to present. And historically, I know this is the first year we are the auditors, but I believe that's typically been omitted in the past as well. We just have to call it out as that is a section within government financial statements that are able to be presented. So it's not that that's wrong. We certainly have a lot of governments that don't present that additional narrative, but certainly it's something in the future. If the board, would like that additional section included, that's something we can work on with Carrie and her team. Really, it's like I said, kind of a narrative written by management about changes year over year. So that's really the primary aspect I think that was the question was around, but I'm happy to expand on that if there's anything further on that.
So then my question, this is Betsy again, would probably go back to Carrie. Are we planning to change the process in that area for next year, or is it something that really isn't so much of an issue to PEB?
This is Carrie Eaton for the record. I don't believe that PEB has ever had that included, so I don't know why we would change the process, but we are able to if the board would like that. Okay,
thank you. The second half was the page on pages 30, 31, and 32 of the report listed as 001-2021, which indicated that the trust fund had to be an adjustment had to be made, and it said that it had an increase or claims expenses and related liabilities by an amount of 5.7 million and 1.5. The next page, it's the next 3 pages, that was 8 million, and a decrease in related receivables by 34.6 million. I'm just trying to understand, because these are pretty big amounts. Self-insurance trust fund, an adjustment to decrease the premium revenue by 7.5 million. Those are big amounts. So those were the 3 pages that jumped out at me, and maybe I'm just not understanding the report there.
Okay. This is Carrie Eaton for the record again, and if I misstate anything, Clifton Larson, please interrupt me. So for the 2021-001, it was 2 journal entries adjustments for claims expenses. So the 5.8 was an error that occurred through the state controller's office. Basically, they just recorded the transaction backwards. So CLA found that and corrected that error. The 1.5 million of claim expense, I believe the HRA liability needed to increase by this amount because of a formula error that was in our spreadsheet that we provided to the controller's office. So we've found that calculation error and we'll correct that for the future. On the next page, the 2021-002 for accounts receivable, there were also 2 journal entry adjustments. The 8 million is to record prescription rebates for Q3 and Q4 of fiscal year 21. And this is because those amounts were not yet received and unknown when the financial sheets were given to the controller's office. So these were adjustments that were needed once those amounts were known. And then the 34.6 million of accounts receivable was a double counted entry in the work papers. And this is the state subsidy amount that was still due as of June 30th. And then the 2021-003 prior period restatement for 7.5 million. I'm not as familiar with this one. There were additional receivables recorded based on postings of 3 months in fiscal year 21. So I believe these were adjustments to revenue that happened after June 30th, but before the close of the fiscal year. So I believe I stated all of that correctly.
So what is the impact, or what did that do to us or not do to us? Or was it just some report somewhere? Or I'm trying to figure out, because to the average person, those look like pretty large numbers.
To my this is Carrie Eaton again for the record. To my understanding, the impact is basically our auditors found items that needed to be corrected and they corrected them. So they're corrected for the future. So there's no impact per se. But
so this
Allison,
is
if you want to jump in.
Go.
Yeah, no, I mean, Carrie's correct. So we did classify these in terms of kind of severity of findings, if you will, because to your point, they are considered material errors. So basically, if they were not corrected in your audited financial statements, the financial statements would not be considered materially correct, but they are correct because management agreed on these adjustments. We made sure that those were properly recorded and presented in the financials. So that's really the biggest takeaway, is that, you know, they were found, discussed with management. Management has a plan to address these going forward. We will be following up on the status of these findings next year. So that is part of our required, audit procedures, and certainly would let the board know if we see similar issues happening. I will say, certainly, us as new audit firm, maybe a different set of eyes on things and different questions maybe that are traditionally asked, and so I think it does just help emphasize having a different set of eyes on things. And we were happy to work with the state throughout this process. It certainly maybe took a little bit longer than all of us wanted because of working through these adjustments as we talked about, but I think we've already had good discussions between Carrie and her team, as well as the state controller's office, about how to address this going forward and kind of having a plan going into this next fiscal year. So I think that's the biggest takeaway, I would say, from a board perspective. And certainly if, from my thought, I guess, would be if the board does see continuing issues for several years, that's certainly a concern, but this kind of sets the precedence, if you will, of, we had these findings, they were corrected. Let's see how it kind of shakes out next year. So that would just be my general thoughts, but happy to address questions or comments on that.
I do have a final question. So these are reports and these have some numbers, but they didn't make cash flow issues. They didn't make us think we needed to ask for more money or less money or change any policy decisions based on these numbers being off, then I'm guessing or asking.
I would probably defer to Carrie on that. I would say in general, we certainly have control recommendations. So, from a policy review, what's kind of done from an internal control perspective would certainly be our focus. But I guess, Carrie, if there's anything I missed there, thoughts on the impacts.
This is Carrie Eaton for the record. No, this doesn't affect how we budget or anything like that. What PEB basically does is we report all of our actual expenses and revenue on a cash basis and what we expected to receive and things like that to the state controller's office. And then they take all of that information and ask questions and then make adjustments to include in the state CAFR. And I am not 100% aware of how that affects the state as a whole. I probably should look into that a little bit more, but it does not affect how PEB budgets or anything like that.
Okay, that makes me feel better then. Thank you.
Okay, if there are no more questions on 4.6, why don't we move to 4.8? Member Kelly.
Okay, can you hear me? Yes, okay. I'm looking for the yellow thing. It actually comes up in delay. Thank you, Chair Fried. So my question is on the master plan document, and I've got some questions around utilization management as well as the exclusion. So I'll ask all of my questions on the utilization management. So perhaps Executive Officer Rich can just answer it all at the same time. So I'm kind of curious about the pre-author or the utilization management, the pre-authorization. The area and the scope continues to expand. I think I think that's true probably of all plans. But I'm just wondering who determines what services require pre-authorization, and then what is the process to come to that? And then the second part of that question is, does PEB do, or have you ever done, a market check to kind of see how our peers, so other government employer provided plans, actually treat the services that we're requiring pre-authorization? And then lastly, and very specifically, can you talk about the addition of services relating to pregnancy? Hopefully you don't need to get pre-auth to get pregnant, but I think the plan document talks about services after the diagnosis. What are those services, and what does that process look like to our participants?
So Laura Rich for the record, and I'm just going to start out with, I'm going to defer some of this to our quality control officer, Tim Lindley, but I will address some of your questions, Member Kelly, first. So first of all, PEB uses a utilization management company, which today is American Health Holdings. During the negotiation process or the implementation process of that vendor, and just to clarify, this occurred prior to meeting Executive Officer, but I am familiar with that process. PEB works with the utilization management company to establish proper and industry standard pre-authorization processes. I do know that when we implemented American Health Holdings, we actually removed a lot of the prior authorizations that we had determined just didn't make sense, right? They were, when pre-authorizations are getting approved at 99, 100%, right? It just doesn't make sense to make people go through a pre-authorization process where it's very, very likely going to be approved, and it's just administrative burden, right? So we removed a lot of those, and so you want to make sure that you are implementing processes that make sense, right? That need pre-authorization for legitimate reasons. So that is typically done in partnership with the utilization management company. And so we are now implementing, because of the contract that was awarded, we're transitioning to a new utilization management company, to where that process has not happened yet, but will be happening shortly. Unfortunately, we're somewhat delayed in that transition process because of some other implementations that have had downstream effects, but we will be having those conversations with United Health and UMR moving forward. Typically, they're pretty standard among utilization management companies. The pre-authorizations are fairly standard regardless of what company you're using, because they're industry standard processes, right? They're just, and I'm probably gonna call on Ms. Bergen on this, because she can probably speak to it a lot better than I can. She's the subject matter expert on utilization management, but she can talk about what kind of industry standard processes that they use in their decision making as to what requires pre-authorization and what doesn't. So is Chanel, are you on? I know she is. I just don't know if she's. Are you able to speak? Okay, there you go.
Chanel Birkin for the record. So just speaking about pre-certification lists, American Health actually does a process where we do an analysis of our entire book of business, and we look for a couple of factors. We will first do a review based on the common pre-certification requirements that we see. And I should clarify, for our book of business, we have many different self-funded clients in addition to PEB. And with that, we support, multiple pre-certification requirements. So when we do a study of our book of business, we take a look at a couple of factors. We look at all of the requirements that we are currently reviewing as an organization for pre-certification. And we will do a study based on those requirements. Do we see that we have saved any days or units? Meaning, we've completed a review of those services and determined that services are being non-certified based on medical necessity. So that's the first portion of the review. So we take a look at those services, and we take a look at the percentage of services being authorized and the percentage of services being non-certified. And Laura Rich had touched on that. So that's the first process. So then when we take a look at the services that are being, have a high percentage of being authorized, we will take a secondary look at that. The second review is we then take a look at those services and see if they have provided triggers into our case management program. So that's where we provide services and support with a registered nurse and provide coordination of care and services. Now, through the CM process, if we realize any estimated savings, and those savings would be attributed to averted use of services, moving members into a lower level setting, as an example, if we realize savings through that process, it's another consideration. So we could have services that are highly certified. However, because we're doing that utilization review, it's creating a trigger into our case management program, which is identifying estimated savings. And the third step is we then do a clinical review. So we have our clinical team actually take a look at the services, taking a look at, are the services being pre-certified or non-certified? Are they driving estimated savings through the case management program? And then we'll do a clinical review just based on national guidelines, industry standards, seeing what services we're seeing out in the market being reviewed, and then we come up with a recommendation. So American Health has a standard recommended pre-certification list after completing that review. And the things that would be considered pretty standard as far as you will always see these items on a pre-certification list are inpatient admissions. So anything related to an inpatient admission, where you could see variance as to the different pre-cert requirements is going to be in outpatient services. So outpatient diagnostic services, outpatient surgery, and any other outpatient, we call that coordination of care. And in that category is where you can see variance and recommendations based on what we're seeing in our book of business. But we do that review on an annual basis. So when we were going through the implementation process with PEB, we did complete an analysis of the current pre-cert requirements that were in the existing plan. And we did a comparison against our recommended pre-certification list. And like Laura Rich said, we made a number of recommendations to remove certain items that we didn't establish any value from a financial value, clinical value, and made some revisions. I'll pause there just to see if there's any questions about what I've covered.
Michelle, did that satisfy your question?
Yeah, I think one part of it, but then if she can specifically talk about the pregnancy pre-certification or case management piece and what that looks like to a participant and perhaps to their provider as well, because I think we get a lot of complaints, and pregnancy seems to be, I don't have the percentages, but I would think there's a lot of people use it, right? So if I could understand that, I'd appreciate it too.
So let me defer that first to Mr. Lindley, who can speak to that. I think we've been working in the past few months to make the master plan documents a little bit more consistent. They've been, it lacked consistency between the three master plan documents, and so he's been doing a lot of work to make them more consistent along the program and not just in the plan itself. So Tim, do you want to speak to that before we have Chanel address that specifically?
Thank you very much, Director Rich. Tim Lindley for the record. Member Kelly, one thing, this actually brings to light what was done when reviewing the master plan documents. Currently, the low deductible and the premier plan have this verbiage that states the UM company should be notified upon confirmation of pregnancy so that they may better manage your benefits. You must comply and cooperate with the UM company. Services are subject to all terms of this plan. And when reviewing the plan documents, this verbiage was not in the CDHP plan document. So what I did is I lifted that specific paragraph to the CDHP and I added a header to that, the header being pregnancy specifically. That way, when we generate the table of contents, it does show on the table of contents. So that was added to the CDHP for continuity between all three plans. There was no changes between the current plan year and the proposed changes for the next plan year. Now, I will want to defer to our subject matter expert, Chanel Bergeron, to speak a little bit more further on that. But I hope that answers your question on why that has been added to the CDHP.
Actually, just a follow-up, if you will. So are you saying that while the master plan document for the CDHP didn't specifically list out pregnancy, that in fact the UM company has been requiring pre-authorization of that piece for the CDHP? Or are you just saying that it was a miss and now it's in? So, has it been done and just not noticed in the MPD, or has it not been done on this plan, but it was done on the other plans, and for continuity's sake, now it will be done on this plan. Sorry.
This is Tim Lindley for the record. Yeah, for continuity's sake, it was added to the CDHP between all three, so all three plans read the exact same.
Okay.
So Chanel Bergen for the record to address the second part of that question. So for pregnancies, the only pre-cert requirements that are actually within the SPD are for delivery. So providers or members need to call in for pre-certification if the delivery admission extends beyond the current federal mandate. And the federal mandate specifies, pre-certification is only required if the days exceed 48 hours for a vaginal delivery or 96 hours for a C-section. So if a member is admitted for a delivery that falls within that time frame, pre-certification is not required. Pre-certification would also be required if during the duration of the pregnancy, the member was admitted for related or unrelated diagnosis. The only other pre-cert requirements that would come into play related to pregnancy would be things like diagnostic testing. And those services are listed within the plan document itself and could include things like genetic testing, for example. There is no specific pre-cert requirement just related to the pregnancy itself or confirmation of the pregnancy.
Thank you for that information. Then I'm actually confused about that addition to the master plan document. It sounds like it's already covered under different areas for either your inpatient admit or your imaging services. These things already require pre-cert, right? So why are we then pulling that one out and focusing it on? Because it also allows you in the future to kind of change it however you kind of feel like it without any advance notice, right? If one day you decide that people do need their OB-GYN appointments pre-certified, then that won't change the master plan document, but it's a real change to our participants and kind of how they see our program. So I am a little confused. I understand the continuity argument, but I don't see why it's pulled out like that. Knee surgery, for example, I don't think is pulled out like that. If someone just needs it's the services themselves as opposed to the condition. But thank you for that explanation.
This is Laura Rich, and actually, this is an area that we were speaking to American Health Holdings about specifically as well, because it was identified. And again, unfortunately, there's still some cleanup work that needs to happen, especially with the transition over to UHC. So there is an opportunity or potentially a chance that we'll bring this back to these master plan documents may come back to the May board meeting with some additional changes. My suggestion here, or what I had planned to ask for requests from the board in this area specifically, is for staff to have the ability to make technical adjustments moving forward, because we also do not have the master plan documents have to be posted by open enrollment. And again, this is the timing of the next board meeting is not sufficient. So we would need to have the ability to make technical adjustments. The removal of this is probably one of them, after having some conversations with American Health Holdings late last week and early this week as well. But we will also, while we will not be making major changes to the master plan documents, there potentially could be some minor changes that may need to happen as a result of the conversations with United Health in terms of how that is going to, how the utilization management is going to look moving forward, because we haven't had the opportunity to have those conversations. I don't expect there to be anything significant, at least in that area, but there is a chance that we may need to make some technical adjustments moving forward in those master plan documents.
May I ask a follow-up question?
Please feel free.
The way that it reads, it says that the company should be notified upon confirmation of pregnancy. Is it the pregnant plan member's responsibility to notify the company of her pregnancy? And if so, what is the penalty for not doing that? For example, would there be some way that her prenatal coverage wouldn't come through, or would some expenses need to be paid out of pocket? I'm just concerned that if someone didn't know that they had to notify the utilization management company of their pregnancy, that they could then be financially liable for more prenatal services and then maybe decline prenatal services, which would have a negative effect. So is there a penalty for not notifying the utilization management companies? I guess my question.
Chanel, are you able to address that specifically from a standpoint?
So from a perspective, the majority of pre-certification notification comes directly from the provider. I would say 98% notification from the provider. As far as any requirement related to just being notified of the pregnancy themselves, there isn't any issuing of a non-certification for those that would adversely affect their benefits. Pre-certification for the specific services outlined as an inpatient admissions or outpatient diagnostic tests. If pre-cert was not required for those services, and HealthScope can confirm this, what would happen is when the claim was submitted from the provider to HealthScope and they were adjudicating that claim, they would potentially deny that claim for payment, indicating that pre-cert is required. However, members and providers have the ability to request a retrospective review, submitting clinical information for those services, and American Health would then complete that retrospective review.
Thank you.
Mm-hmm.
So it's Michelle here. The other area, and this is really a general question. So the exclusions that start on page 93 of the document or 165 of the PDF. I was really confused when I was reading these exclusions, especially the ones that pertain to the NRS changes. It seemed like the one on contraception, the continued medical treatment, controlled substances, they're in the plan under exclusions, but it's really confusing to me because they're actually, NRSs are saying that health management organizations need to cover these, and then PEB's got them in their exclusion. So can someone kind of talk about, it's the, as I say, contraception, continued medical treatment, controlled substance. I think there was more, but because it was a general question, I just thought I'd pose it. Why are those directions to health management organizations in the PEB plan as exclusions?
This is Tim Lindley for the record. Once again, this was a continuity between all plan documents. So if you looked at the current plan documents, the low deductible and EPO plan has those listed under exclusions. Obviously, it was copied over to the CDHP, so it's more for ease of use and easy understanding. Now, the NRS, the subheading is benefit limitations and exclusions, and the NRS does show that if there is a limitation or exclusion, for example, contraceptives, that this NRS supersedes any potential limitations or exclusions in the document.
This is Laura Freed. I have a question, and I think this is probably for Mr. Lindley. So in listening to all this discussion, what I'm getting is that nothing about delivery of care, because we started the question, discussion about pregnancy. Nothing about delivery of care is changing. We're aligning the MPDs for all of our plan choices to law and each other. Is that right? Can you please confirm or deny that?
This is Tim. Chair Freed, that is correct.
Okay, thank you.
So it's Michelle here. So I appreciate that clarification. I think what I experienced as I read through this is that, this is the rules of how the plan operate and how PEBP manage the plan. But I do think that it's not very understandable. It's not from an exclusion point of view, and then from the utilization management, it's contradictory. And so I would suggest that once I understand that you're lining the plans up and the language up, and that's great. But I do think that that there needs to be some work done on using plain language to describe what's covered and what's not covered, because participants should be able to understand this easily, and we should be able to point to pages and say this is where it's outlined. Like as plans, we're mandated to operate it per the plan document. But if an employee can't understand it, or we have things listed that need pre-authorization, but in fact, when they call to pre-authorize it, someone who's just been diagnosed as pregnant is going to be told, oh, no, you don't need to do that now. It's only when you're going to give birth and if you're going to be past a certain number of days. So it's confusing for our participants who utilize the plan for it to kind of be circular. And so my request would be that, and I know everyone's just trying to get by at the moment, but over the next 12 months, that we should also be looking at summarizing and clarifying what's actually meant in these exclusions and the utilization management. Thank you.
So Laura Rich, for the record, I appreciate that, Member Kelly. Actually, the master plan documents and the development of master plan documents were added to our TPA RFP, and so it is part of it, specifically to address your comments right there, because we recognize our MPDs are a product of over a decade of just of additions and edits, and it's gotten to a point where we can probably do better. And so, but with the limited staff we have, we don't have the ability to do it in-house completely. And so we added that to the RFP as a requirement, and we plan to make that something that we work with UMR on moving forward. Unfortunately, we haven't transitioned yet, obviously, but we expect these to look a little different next year. Not only do we expect them to look different, but there's probably going to be some work done in terms of our benefits and making some recommendations and changes moving forward. Specifically, the one thing I can think of is dental, right? Some dental changes, and then specifically, to other medical subjects as well, or topics as well. But this takes time. And unfortunately, we just, the last 2 years have been a little chaotic for PEB, and we have not had time to really dive into this. But this is something that is on our radar, something that we have put on our, on our whiteboards as projects that we want to work on moving forward.
Okay, this is Laura Freed. Okay, thank you. If there are no more questions about, oh, there are.
Well, Chair, actually not about this item, but I missed at the 4.6 when we moved from it. I was comfortable with the deficiency discussion, but I still wanted to talk about the retiree loss position. Okay, so, but I don't know if everyone else was done with that other one. I think
okay, so let's, let's put a pin in 4.6 for a second. 4.8, going once, going twice. Okay, let's go back to the retiree loss.
Sorry about that, but I missed that, and then we
Not at all. Go ahead.
I'm looking at page 5 of the state retiree health and welfare benefit statement of changes. And I know I discussed this a little bit last year because in 2019, the net position at the end of the year was a positive number. In 2020, it was the retiree net position was negative 5.6 million. And now the retiree net position is basically a negative 10 million. And so I'm just curious about if the retiree net position keeps going down and down and down. Is it funded, that negative position, then by the actives, or just curious about that because that is definitely going down?
This is Carrie Eaton for the record. And yes, you are correct. This is what we call our Reggie Subsidy, and it is built into our budgets, and then it is put into law during legislative session. So it is a set subsidy amount. So even if our rates increase, we're only receiving this smaller amount of subsidy. So this is something that has been getting worse each year. We are not getting enough retiree subsidy to support the amount that we need. So this next budget building session, this is something that we are going to have discussions with to try to see if we can reduce the active subsidy and increase the retiree subsidy, or talk about ways how to fix this issue, because this is going to be a prolonged issue that keeps compounding. And I know Director Freed may have more to say. She knows about this as well, but I'm not sure if I sufficiently explained that.
No, I don't think I want to venture into this one. Thank you, though, Carrie, for the.
Sorry about that.
So this is Betsy. I mean, it doesn't really have to do with approving the audit report or not, because it is what it is. But I don't know at what point there's an obligation from the board or the budget. Obviously, everyone's getting the care, but I know retiree care is more expensive than active care.
Right. This Carrie Eaton for the record again. This is something that is definitely has to be fixed budgetarily and legislatively. So it is definitely on all of our radar, and we will do our absolute best to try to undig this hole.
Okay, with that, if no one on the board has additional questions about either 4.6 or 4.8, I'll accept a motion to accept both of those items at once.
You're free, Tom Verducci. I'd like to accept 4.6 and 4.8, but I'd like to add the language on 4.8 to allow staff to make technical adjustments.
Okay. Do I have a second?
This is Leslie. I'll second.
Okay, thank you. So to recap, we'll accept 4.6 and 4.8, and Mr. Verducci's motion includes authorization for staff to make technical adjustments on the plan year 2023 MPDs. Does everyone understand what that means in the context of Executive Officer Rich's previous comments about needing to do that going forward? Ms. Kelly.
Michelle here. Thanks, Jeffrey. Just wondering if, as a friendly amendment to the motion, if we could ask for, once these amendments are made, that the master plan documents be brought back to the committee for review. Even if it's just informational.
Is that okay with you, Mr. Verducci, Ms. Biddleston?
Tom Verducci for the record. Yes, that would be just fine.
All right.
And yes, that's fine.
All right, great. In that case, all in favor signify by saying aye.
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 Aye. Any opposed, say nay. Okay, motion carries. Thank you very much. With that, we'll move on to agenda item 5, the executive officer report. This is an informational item only.
Thank you for that clarification. I actually see that it's listed as an action item on the report, so
Yeah.
I apologize for that.
No, it's okay.
We reuse the reports when we write these, and sometimes we miss that area, so I apologize for that. Laura Rich for the record. This is the executive officer report to provide the board and the members of the public information on general PEB operations. First is staffing update. Unfortunately, PEB is not immune to what I think most other state agencies are going through and the nation in general. We continue to face staffing challenges, particularly in the member services unit, which is the PEB call center. We've had some recent promotional opportunities where staff have gone to other agencies. We had a long-time staff member retire as well, and so we've got a decent amount of vacancies at PEB. And all those supervisory staff are actively working to fill these vacancies. Even when we do fill these vacancies, there's going to be a significant amount of training that is required in all of these roles. So having sufficient staffing available during open enrollment is definitely a concern of ours. We are doing our best, but PEB is a very complicated and intricate program, and so it takes staff quite a long time to get up to speed. Of the 34 staff right now, we have 9 vacancies. So we're operating basically on slim pickings there, right? I mean, everyone is doing 2 or 3 jobs at this point. 5 of those vacancies are in the member services unit. So you did hear through public comment that hold times are long. We historically, if you call PEB, we typically answer the phone very quickly, and we're able to help our members very, very quickly usually. That is not the case. We are very understaffed, and on top of some of these other issues that you're going to hear in future agenda items, there's a lot going on and not a lot of staff, and so that is it's an unfortunate situation. But I just want to thank all my staff, because everyone is working very, very hard. And like I said, everyone's doing the job of 2 or 3 people right now. And so I want to go on record and thank everybody at PEB and thank them for, doing the hard work that it has been necessary the last few months, 2 years. The next one is budget and legislative session preparation. On March 9th, as it happens every other year, the governor's finance office held the state's budget kickoff meeting. That is when state agencies are basically told, they're given directions on how to build their budgets and prepare for the governor's recommended budget. So at that time, state agencies were given direction to maintain flat budgets. That means that we are working with the same dollar amount in the next 2 years as we did in the current biennium that we're in. So because of that's concerning. Because of that, the rising cost of healthcare, flat budgets for PEB really amount to budget cuts. And the reason why is the same dollar doesn't stretch it as far. And so in order to stay within those dollar amounts in that budget, benefit cuts are going to be necessary in order to stay within those same budget requirements. So literally right after this meeting was over, I definitely communicated PEB's concerns about this to the governor's office and the governor's finance office. And we're already in discussions regarding possible solutions and alternatives to avoiding this. They are very receptive to the need for PEB to possibly get an exception from these flat budgets. And so we are working with them to see what we can do to avoid a budget cut situation for us, or a benefit cut situation for us. In addition to budget building, bill draft requests are another area that must be considered as we prepare for legislative session. Those are, program changes that we need, things that might be addressed in, that might need to be changed in NRS. So non-budgetary BDRs, those are things that, don't have a fiscal impact, are due by May 20th, 2022. And budgetary BDRs that have a fiscal impact greater than $2,000 are due by September 1st of 2022. PEB will be bringing budget enhancements and possible budgetary BDR proposals to the board for consideration in May. But in that time, board members are encouraged to propose any kind of suggestions or ideas that they may have, and PEB staff is happy to incorporate that into our board report in May when this comes to the board. Also, a quick FSA update, the flexible spending arrangements, they're currently offered at no cost through HealthScope benefits. When I say no cost, it's no cost to PEB. It's a $3 per month monthly fee to members that use this, but it is no cost to PEB. Because of the low utilization and work that is required to maintain a $0 contract, PEB chose to offer this product as a voluntary benefit. And initially, Benefit Focus did indicate that they were able to support this decision and could offer it through their voluntary benefits platform. However, recently we received confirmation that this is not the case. And so instead, what we did is we decided to implement this benefit through the UMR contract. So that's the TPA. Since it was included as part of that RFP, and it's not going to increase the contract amount, there's no contract amendments or anything like that that will be necessary, but I did want to bring it to the attention of the board that this is not going to be offered as a voluntary benefit, and instead through the TPA, but it will continue to be offered similar to how it is today. So with that, I will take any questions.
Michelle here. Executive Officer Rich, regarding the FSA, so giving it to UMR as opposed to the HSA provider, can you talk about how are they going to verify kind of that people are eligible, and which plan, whether it's the full FSA or the limited scope? How will that all work?
So, Laura Rich, for the record, I do not have the details on how their processes work, but I will see if someone from UMR is able to speak on this. And I know we do have representatives from UMR on.
Laura Rich, this is Rhonda Huckabee from HealthScope Benefits. So every year, the PEB participants, if they elect to enroll in one of the FSA options, they have to complete a enrollment form, and that is sent directly to HealthScope. And our CDH team, which was also the team that currently does the HSA HRA administration, handles the FSA administration. And once that is loaded into our system, they work directly with the pay centers.
Thank you. Just a point of clarification, just so that I can line everything up in my lineal head. So we keep referring to them as HealthScope, but come July 1, the contract with UMC and no longer with HealthScope. Can you confirm, is staffing staying the same? Is the team staying the same? Or are we going to have a process shift since Ms. Huckabee refers to herself as health scope, I'm just trying to.
So Laura Rich for the record, yes, so much of the Health Scope team, and I would say all of the Health Scope team that is assigned to PEB right now, it will continue with PEB. Obviously, there's going to be some transitional changes going over to UMR. I think that a lot of the changes that you'll see are going to be beneficial, especially to members through the member portal and things like that. But the staffing is generally staying the same with some possible additional resources as well.
And so the FSA process that Ms. Huckabee talked about, is that, so it's the process that they use today and it'll just continue to be the process for the new plan year? Is that right?
Correct, that process will remain in place.
Okay, this is Laura Freed. Anybody else have questions, comments, concerns on agenda item 5? Okay, so with that, why don't we take a 5-minute break? Ooh, perfect, it's 10:45, so come back at 10:50 and we will dig into agenda item 6. Okay, everyone, it is 10:50. I'll call the meeting back to order. And we'll move on to agenda item 6, COVID-19 update, which is an action item. And I'll let the executive officer take it away.
All right. So this is a COVID-19 update. I'll start out with a little bit of the background here. On February 21st of 22, the governor reinstated the weekly testing requirements for unvaccinated employees. And the administration and the costs associated with that, with the testing, the weekly testing, was transitioned from the Division of Public Health and Behavioral, or Division of Public and Behavioral Health, over to PEB. So through a partnership with HealthScope Benefits and Quest Labs, as of March 14th, we had purchased and distributed approximately a little over 40,000 tests to state agencies at a cost roughly of about $1.3 million. Those tests were to be used for the departments to distribute to unvaccinated state employees so that they could then perform their weekly testing requirements. The board, as a response, approved the implementation of COVID surcharges for unvaccinated members and their dependents starting July 1st of 2022. So we've continued to work very closely with the governor's office and DPVH to track and monitor the impact of COVID on the employee workforce and also additionally on health plan costs. Recent data shows a steady downward trend in cases, and positive results among the state workforce have dropped to less than 1% of the workforce. So the employee vaccination and testing program was designed as a public safety measure. And that data shows that, you know, the state is achieving its goals. So in response, the governor's office has provided department directors with guidance that has basically providing each agency head discretionary authority to administer testing in a way that best manages their workforce. However, the state will be formally dropping its weekly testing requirements for unvaccinated employees moving forward. And that actually became official earlier this week. The governor's office did distribute a memo to employees addressing this. So along with the sharp increases in vaccinations, the state has seen a decline in both the number of employees with COVID and the severity of those requiring hospitalization. This, coupled with the end of a formalized testing program, lessens the fiscal impact on PEB and thus the need for a future surcharge. So instead, the governor's office and governor's finance office will be supporting PEB with other funds to cover the cost of employee mandated testing that has been incurred up until this point, and they're prepared for any potential spikes moving forward. So the recommendation here is that the commitment from the governor's office to provide fiscal support for COVID costs eliminates the need for PEB to impose the policy to add COVID surcharges effective 2022, as approved by the board in December. Staff is recommending the removal of those surcharges. So I will stop right there. The rest of this is really just COVID-related utilization on self-insured plans, and I think that is just informational for the board to review on just what's happening with COVID.
Okay, board members, questions, comments?
Tom Verducci for the record.
Okay.
You know, my meeting notes on this, I wrote down slippery slope, and I heard that twice during the public comments. And, you know, I wanted to point out, I really felt on this, we were going down a slippery, unknown path that no other states were doing. And, you know, a surcharge is basically a tax. And state employees haven't had raises, they can't afford it. And I'm very thankful for the governor's office dropping it at this stage. I really felt that it was wrong. Member Barnes and I did stand up against this and spoke out. I'm still opposed to it. State employees cannot afford it. And I still do not support any kind of surcharge. And I'm very hopeful and confident that the board doesn't move towards an unnecessary tax or surcharge to a group that cannot afford it. And I think that we should do the right thing and drop this and move on. That's my comment.
Other comments? Okay. Boy, this is going to be quicker than I thought it might be. So one clarification on my end, just for Ms. Rich. So the staff report says, instead, the governor's office and governor's finance office will be supporting PEB with other funds to cover the cost of employee mandated testing incurred up to this point. And about how much was that? Did I miss that somewhere in the report?
Yeah, so it's in the report, it was $1.3 million. That may have changed since the report was written, but they have committed to provide reimbursement to PEB at whatever that cost is.
But okay, so more over and above the 1.3 million that PEB has already spent for the tests, they're committed to providing claims reimbursement to PEB.
So
God, could there be another? I'm sorry. I'm sorry, I didn't mean to talk over you.
No, it's fine. Laura Rich, for the record, not claims reimbursement, but specifically for those testing costs. So at the time that this report was written, that was what had been ordered thus far. That changes every day based on the need of the agencies. And so that may have changed slightly since the time that this report was written.
Okay. So I don't want to have a situation where we go back and forth. God forbid there be another variant and another surge. So if we remove the surcharges, which is great for participants, but we incur a whole bunch of high cost claims, do you have a commitment that these other funds will pay for those?
Laura Rich, for the record, the commitment was to pay for those funds that have been used so far to cover the testing costs. And if there is another variant, that they'd be open to discussing, obviously, solutions for PEB in the future. Should there be any issues moving forward where PEB is on the hook for high cost claims because of a new variant.
Okay. Betsy?
Took me a minute to unmute. And I'm supportive of not having a surcharge. I don't like it very much, but I'm just curious about these reports you said that are just reporting. On February 10, it said that we had paid dollars per year, almost 2 million. Oh no, that's just, almost $2 million paid by year, almost 2 million. And then in March, it was over 3 million. So was there a huge claims lag that ran with it be increasing by over 1 million in 1 month?
Laura Rich, for the record, that is what I would suspect, given that there is always a claims lag, and there was obviously that variant that we experienced over the winter. Is there anyone from HealthScope that can maybe speak to the data on this and the experience specifically with COVID? Because I know, it's as Betsy mentioned, there's a very significant cost with COVID specific claims. So it's something that it caught my eye as well. Moving forward, if there are any more variants, is this a cost that PEB is going to have to absorb? It's definitely a concern. But it looks like Nathan Meyer from UMR can speak to this a little bit more as well.
Yeah, hi, Nathan Meyer for the record. So Betsy, can you point out which specific numbers you're talking about where you saw the increase? I'm looking at the February report.
I'm looking at the slide put in the PowerPoint presentation that's right after Laura's report. And it says COVID-19 diagnosis confirmed. This is dollars paid by year. And February 10, I'm thinking that the 1.9 million is from June to February 10 because it says paid by year. So I'm thinking it's our fiscal year. So we're under 2 million for the fiscal year. And then about 3 pages down, you have a March one that says now it's 3.2 million. So it went up over 1 million just in 1 month when it was under 2 million for like 6-7 months. And that could be all the January surge. I don't know.
So it's a cumulative number by year, Betsy. So we had another month of paid claims come through, which is why there's the increase.
But it was a huge increase because the first, like, if it's the state year, not the calendar year, I'm guessing it would have been 7 months for 2 million, and then 8 months it went to 3 million. So is what I'm thinking I'm seeing.
I believe this report is calendar year based and not specific to PEB's plan year, but let me confirm that for you.
Okay, and then my question is, because the year before we paid 11.5 million, so we're running about 1 million a month in claims for COVID?
Correct.
And this is Laura Rich. Nathan, can you maybe speak to, what UMR is seeing maybe across your book of business in terms of COVID claims and COVID experience, and how the PEB experience may compare to that?
Yeah, I would say generally speaking, Laura, that we are starting to see it come down. Similar to the points you referenced earlier about positivity and some of the other metrics you referenced. So we are starting to see it come down. And if it's something the board would like to see, we can certainly provide kind of some book of business comparisons as well, so we can compare PEB to the UMR book of business.
This is Laura Freed. I would certainly like to see that comparison to the rest of the book of business. Yeah.
Okay, we can put that together.
Okay, so it looks like nobody has any more questions. If nobody wants to continue to ask PEB staff questions, I guess I'll accept a motion to eliminate the surcharges that were previously approved by the board that were supposed to be effective July 1, 2022.
Tom Verducci for the record. So moved.
Thank you, sir. Do I have a second?
Janelle Woodward, I'll second.
Thank you. All in favor signify by saying aye.
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 Any opposed, say nay. Okay, motion carries. Thank you, guys. All right, we are moving on to agenda item 7, enrollment and eligibility system implementation update. I'll turn it over to Mr. Proper.
Nick Prober for the record. Thank you, Chair Freed. I'll be providing an update on the enrollment and eligibility system. This is a very lengthy report with different categories, including 3 staff recommendations at the very end. So PEB's new enrollment and eligibility system is managed by Benefit Focus, and it went live in January. And although the contract is with LSI, the bulk of the subcontracted work is performed by Benefit Focus. There have been many challenges and risks, which I will go over each, including data issues, demographic file feeds, accounting and billing, system functionality, and file integrations with associated work orders for each. The first I'm calling data discrepancies, but this is data integrity and reconciliations that occurred from the system change. This means that there are differences on some member accounts other than what they are supposed to be or what they were prior to the conversion. And this occurred due to two main reasons. The system change with some member data, including coverage levels, were converted to something other than what they should be. And then this also occurs through the transmission of incorrect data on file feeds to the carriers. So think of it as bad data in, bad data being transmitted out. And so when the transition and data conversion occurred from our prior system, some member coverages were changed to not what they had. And this includes years of service also being changed or calculated differently. And all of these changes or discrepancies contributes to wrong deductions taken out and wrong billing, as well as wrong coverage levels causing disruption with members accessing services. Benefit Focus has attempted to reconcile and audit the data, but it was not done properly because anytime PEB staff look up historical data on many accounts, it is absolutely different than to how Benefit Focus converted it. And again, this includes members in a different status, plan, or coverage tier. And PEB staff many times will come across an error for one that impacts many more, up to thousands more being impacted. Unfortunately, the impact is currently unknown as we're relying on member feedback, internal audits, and feedback from carriers and agencies. So staff is continuing to do their best to manually reconcile and correct accounts as immediately as possible, including performing urgent updates with the carriers so services can be accessed. This implementation focused heavily on demographic file feeds with central payroll and NCHI. The idea with this is that agencies know what statuses their employees are supposed to be in, meaning their personal information, but there have been complications and added workloads on all sides because central payroll and NCHI employees, for example, are no longer able to have just one address in their HR system and a separate address with PEB. And so employees to wish to have these separate addresses are affected. And so we're receiving many complaints about this currently. Another category or issue is seasonal workers or critical hires coming back to central payroll and NCHI. When they're being sent on demographic file feeds, it's overriding their previous coverage, which is typically retiree coverage and PERS deductions. And it's moving them back to active coverage, complicating the billing component even further, requiring adjustments and refunds. And so to get these files to work correctly, it requires further configuration on both the Smart 21 and NCHI sides. To mitigate this, we have paused both demographic files and are reverting back to a manual process in which it worked before. Agency representatives go into the system, put the employees in whatever status they should be, and nothing is overriding that with this manual entry process. Now on to billing, which has been a bane of our existence since last board meeting. As last board meeting, LSI went on record and promised that in February, a billing platform would be available, and PEB staff and members still do not have access to the billing platform, even a basic billing platform, not a complete solution, but a basic platform is scheduled for mid-April. A complete billing solution to meet PEB's needs and carriers' needs, agencies' needs, is at least 12 months away, which would require a completely one-off customized development with unknown costs at this time. To continue with all the accounting and billing issues, invoices continue to not be produced. Employees in a direct billed status have not received bills for their health insurance, causing PEB to manually create letters to ask direct billed members to pay premiums based off of old information. Deduction files with PERS, central payroll, and NSHE continues to need constant fixes and development work for deductions to be conveyed appropriately. And file integrations with our Medicare exchange vendor via Benefits or Willis Towers Watson needs new files developed so exchange members can be reimbursed appropriately through their HRA. But there's an issue there because with the data conversion, members' years of service subsidies were calculated differently, affecting their HRA. Again, the volume of impacted members is unknown. Some members are continuing to have incorrect deductions without being refunded for almost 4 months. Direct billed members with voluntary benefits have never received a direct bill, and PEB cannot create a voluntary benefits direct bill on this member since we do not administer voluntary benefits whatsoever, so we have no visibility into this. The long-term effects of billing is that PEB will not have the required documentation to provide auditors for this time period, which may lead to delayed audit results and audit exceptions. Again, PEB staff are coordinating with all agencies and members on a very manual basis to keep track of what refunds or deductions need to be corrected as we continue to have zero visibility to the billing platform. Now to system functionality, which this list includes various items that all contribute to manual work on PEB staff and members and just frustration across the board. So Benefit Place is the name of the member portal and the admin staff portal, and it is not a true CRM system as it lacks much needed functionality. For example, Benefit Focus notified us in January of some fixes to the system, including a message center function to be deployed in February. Never happened. Staff cannot add notes directly into a member's record. Staff and members themselves cannot cancel out a life event that they started. So every time they need to make a change or cancel out a life event, we have to send a case to Benefit Focus to cancel. And a very important item for system functionality relates to PEB's open enrollment. PEB's rules for open enrollment is a passive open enrollment, meaning that members who wish to do nothing will keep their same exact coverage or elections for the upcoming plan year. It was recently conveyed to PEB that members in an HSA plan will have to reattest their eligibility and reselect their contributions, essentially turning a passive open enrollment into an active open enrollment for everyone with an HSA account. What that means, it will cause thousands of tasks on PEB eligibility staff to have to approve and heavy communication to everyone to basically turn this passive open enrollment into an active open enrollment so these members don't get missed. The impact of just the system functionality causes internal operational processes and procedures to take longer, being more manual, which also means new coverage and coverage changes for members will take longer to take effect. The mitigation, there really is no mitigation on this as the current system functionality will remain, continuing to the added workload on PEB. Their system is what it is, which isn't good. Now to a very large category, being one of the largest risks, in my opinion, are the vendor file integrations with the associated work orders. So vendor file integrations with our vendors are still not set up and working as expected, with multiple integration calls continuing weekly, with still new issues being discovered on a weekly basis, blindsiding PEB entirely. PEB recently found out through our own research that when members initiate a qualifying life event, a marriage, birth, divorce, to have either dependents added or dropped, if they have not submitted the documentation loaded, the entire coverage tier is disenrolled from benefits. This is really unacceptable. So if anybody wants to add a new spouse and the documentation isn't uploaded day one, all members are disenrolled and not sent on carrier files until this documentation is loaded. And we give members X amount of days. Well, with this, if they don't do it day one, it's bad. Benefit Focus is also unable to send HealthScope benefits, care management, and enrollments appropriately on dependents. This was also not conveyed until recently, causing PEB, HealthScope benefits, and ESI with the only option to pursue a new care management file amongst ourselves without Benefit Focus. The current estimated cost for just this is $10,000. And with this direction, if we were to go down this path, means care management enrollments would not be reflected in the Benefit Focus system at all, forcing PEB staff and members having to reach out to HealthScope and DSI to confirm enrollments every single time. So the impact of these file integration issues is numerous. Members being dropped entirely or conveyed in a different coverage level than what they should be on files, causing their deductions to be incorrect and causing them unable to access services, again, with added manual workload on all PEB staff, carriers, and agencies. Unfortunately, the current system, functionality, and processes will again remain unless more work orders with unknown costs occur for development, if even possible, that future development would correct these. So now I'll go through each invoice relating to each file integration. And the total of these invoices here are $500,000 almost, total 470, but we're recommending to not pay given they're not working as expected, still in the testing, configuration, or creation process, still with needed workarounds and future work orders. So the first and largest work order is the Central Payroll Advantage integration. So what this means is Smart 21 was scheduled to go live in January, and all the work that we've been doing in the summer and fall was to prepare for it to go live with Smart 21. Well, that was delayed, causing a shift to the current and prior Advantage payroll system with Central Payroll. And we're recommending to not pay this because LSI owns both the Smart 21 and PEB contracts, and the shift was caused by a Smart 21 go live delay. Nothing in PEB's control or even Central Payroll's control. And the only actual option presented to us from Benefit Focus was to continue with LifeWorks for January, which was not possible to have two separate systems at the same time, not speaking to each other. Just not possible. And so this file integration is not working as deductions are incorrect for every single Central Payroll employee, every single one, whether it's for HSA contributions, voluntary benefits, or premiums due to Benefit Focus's 1 cent rounding rule, because they can't accommodate splitting deductions equally, even though that's how they set up the system. And so there are not adjustment files being sent to provide members with necessary refunds, causing Central Payroll, especially KENA and PEB, to manually keep track of all members needing refunds. That's just the first work order. The second one is the ESI integration file, and it's not working as expected, with, again, members having disruption in coverage. The proposed next step to correct this is a second work order estimated to be another $20,000 on top of the current $20,000, just so Benefit Focus can convey the necessary information in a manner that ESI can load. Again, unknown outcome. The third work order is for the HealthScope benefits file integration. And I just want to preface this that HealthScope benefits IT department has spent hundreds of hours customizing, configuring, creating brand new files and formats, and reconciling past files to accommodate Benefit Focus, still with some members not being sent to them properly with member disruption. As I previously stated, we recently found out Benefit Focus cannot accommodate conveying care management enrollments appropriately, despite this being in the RFP and having integration calls for over a year. The next two work orders are both for Medicare Exchange with Willis Towers Watson. One is an HRA file, and this relates to HRA reimbursement. And so this is a two-part component. One, it requires an HRA dental reimbursement file, which has not been implemented until just last week or so, and it was implemented incorrectly, as we just found out they doubled dental deductions on roughly 4,600 members that will now need refunds in April. So we're working with PERS and everybody to come up with a solution and send out a mass communication on this, hopefully tomorrow. Also with this HRA file, if the years of service is calculated incorrectly on many members, it changes the amount of their HRA, causing more member disruption and added manual workload on PEB and Willis Towers Watson. The second file with Willis Towers Watson is the eligibility file, which it's almost April, is currently still in the testing and QA process because it hasn't been correct yet. We just recently finalized requirements and specifications after over a year of calls, and the outcome is currently unknown. Willis Towers Watson actually waived a $10,000 vendor change fee, assuming this integration and file feeds would be simplified, which has not been the case. And the last work order is for a Medicaid comparison file. And this is still in the testing and QA process as well, without an estimated completion and go live date, requiring further configurations on both Benefit Focus and the Medicaid side. Now I'll present the three different options to the board, followed by our three staff recommendations. The first option is stay the course with LSI and Benefit Focus. The positive outcomes, if you can even call it that, are the system and processes remain the same, which is not ideal, obviously. The risks are everything presented in this report, everything presented in January's report, not including the day-to-day things. Just basically, the functionality to suit PEB's needs and processes does not exist without a path forward to make them exist. File integrations with vendors and agencies still need solutioning. A complete billing solution to suit our needs is not in the works anytime soon. And to get everything to where we would need it to be will cause hundreds of thousands of dollars on more work orders on top of these ones listed. So in the interim, everything stated is causing, again, more manual work and frustration on everybody. That's option one, that we do not recommend whatsoever. The second option is LSI pursues a new subcontractor to replace Benefit Focus with the same contract terms. The positive outcome is unknown, obviously. The risks include disruption to members and carriers, since it will be another change. And this will start a brand new implementation with all entities, vendors, agencies all over again. That will take another 18 months to 2 years with an unknown outcome. And I can already tell you there will be reluctancy from everybody to do a brand new implementation with a brand new vendor all over again. If we went down that path, our carriers may start charging us. I mean, like I said in the prior one, HealthScope has spent hundreds of hours. So if we switch to a new vendor, they may want to send us a work order for all their man hours being wasted. I don't know. And so we're recommending option 3, which is PEB to pursue an emergency contract using a solicitation waiver to contract with prior enrollment and eligibility vendor LifeWorks and concurrently release a new RFP. And so the positive outcomes with this option are system functionality, PEB processes, file integrations with vendors and agencies, and billing processes work to suit all parties' needs. And for voluntary benefits, we are currently researching the gaps, but a recent update from LifeWorks and their broker CoreStream is that they can continue to support the existing offerings. Again, there are still risks with this, as with all options, but I believe this to be the minimal risks of the three. And again, this includes a short notice disruption, since it will be a change of systems requiring heavy communication. Data conversion and reconciliation will have to start all over again, given the data coming from Benefit Focus can't truly be trusted. Another issue is if Smart 21 payroll does go live for July, the timeline to integrate and test with them is shortened. And with all of these three options, we are recommending a change to PEB's open enrollment to be May 16th to May 31st. So it cuts it by 2 weeks, but I believe we need that runway regardless of what option occurs. And so now I'll formally present the three recommendations. Recommendation 1 is staff recommends not paying the costs of the file integration work orders, as they are either not working as expected, arguably in scope, or still in the testing and creation process, or a combination thereof. Second recommendation is we recommend option 3 to pursue an emergency contract with LifeWorks while releasing a new RFP in the future. And recommendation 3 is we recommend changing open enrollment to May 16th to May 31st. And with that, I can either answer questions or pass the presentation off to LSI, whatever you prefer, Chair Fried.
Thank you, Mr. Proper. I think the first thing I'm going to do is ask for the verbal update on voluntary benefits. That is the last paragraph in the staff report before the recommendations, to see if, since the packet was printed, you have some more information on that.
Chair Fried, are you asking somebody from LifeWorks to speak on that?
I'm asking actually you or Ms. Rich to speak on that if you have some.
So Nick Proper, for the record, yes, this update was literally this week, that they can support the existing offerings.
They can.
Yes.
Okay.
That was this week after this board packet was put together.
Right. Okay.
Yes.
All right.
Laura Rich, for the record, I just want to add, and maybe Nick, you can provide more details around this, that some of this will also depend on what kind of data that we get, that we're able to get from Benefit Focus, should we go down this path, because in order to ensure that there's seamless transition, I think that LifeWorks is going to need that information and need data from Benefit Focus. And so there's potentially, we're going to try to mitigate the disruption and potentially even make it seamless. But I think a lot of that is dependent on what LifeWorks gets from Benefit Focus.
Nick Proper, for the record, I've also had preliminary talks with some of our voluntary benefit carriers just to ensure that if Benefit Focus cannot send those enrollments to LifeWorks, the carriers absolutely will be able to.
Okay, thank you very much. I think now that I've clarified that, I think the second thing I'm going to do is ask the board members what questions and clarifications they would like from Mr. Proper on the staff report. Member Kelly.
Thank you, Chair Fried. So, Mr. Proper, thank you for your report. I guess you focused a lot on kind of the risk and the issues with the current provider. Can you talk about the effort from all parties, the state payroll, NG payroll, PEB staff, by going back to LifeWorks? Because obviously there's been a year where there's been 6 months, I think, where they've had no data. But can you talk about kind of what, I've heard the word cleanup used, but can you be kind of specific about what needs to be done to do that?
Nick Proper, for the record. So the biggest component, in my opinion, is sending the data back to LifeWorks in a manner that they can upload into their system, assuming it's correct. And that will be the biggest challenge. I think everything else will be minimal because the prior file integrations, processes, everything will be turned back on exactly how it was. All the agencies and the carriers are familiar with that process. So really it's going to be the data integrity and the data conversion, since it was converted to something other than it was from LifeWorks. And so now we have to figure out, okay, what should it be to send it back? So, I mean, every day we're still trying to reconcile this without LifeWorks and without this board recommendation regardless. And so that's going to continue. We're going to have to look up historical data, work with all of our carriers, and continue that. But the positive is that LifeWorks knows how to calculate rates correctly and calculate years of services correctly. So we'll send these members over with X amount of years of service. They'll calculate it correctly, as opposed to what Benefit Focus has done with different HRA amounts or different years of service. So yes, every one of these options has risks, but this will absolutely be the minimal risk presented.
Member Biddleston.
Can I just ask?
Oh, I'm sorry. Go ahead with your follow-up. I'm sorry, Ms. Kelly.
Oh, thank you. So just a quick follow-up. So just to quantify the effort, you've talked about kind of obviously new employees, people who make changes. Do you have an estimate on the percentage of the covered population that doesn't make changes? And, you know, for example, myself, to share personal information, I haven't changed my health plan since the CDHP was introduced. So I've just stayed there. I haven't added, I haven't deleted. And I assume for someone like myself, you'll just be able to pick up my record and drop it in. So no harm, no foul. What percentage of the population?
Whoops, Ms. Kelly, you got yourself back on mute. We didn't hear the rest of it.
Sorry, I was just saying what the rest of the population, you know, what percentage might be easy versus kind of those problems you have to solve?
So Nick Proper for the record. So we typically see those numbers after open enrollment. We get a report of how many people actively went in and made a change and how many didn't. And each year, the vast majority do not make changes during open enrollment. Of course, that doesn't include all of the changes throughout the year of new hires, terminations, or somebody with a qualifying life event. I don't have those figures in front of me, but it is not the majority. I can tell you that very, positively, that it is not the majority. The majority do not make changes throughout the year.
Okay, I'll go to Member Biddleston.
Thank you, Leslie Biddleston, for the record. I guess I have a comment that's going to lead to a question. So it sounds to me like we were looking for a vendor that had a product available that can do a bunch of things. And knowing what we know, those of us that have been around a while know that not, a product off the shelf is not going to fit our needs immediately. It might need some changes and some configurations. But from what I heard from Mr. Proper, it sounds like the product that we were given lacked some basic functionality that should have already been there. And now the vendor is trying to charge PEB for adding some of that basic functionality. So I guess that's what I think I'm hearing. So my question to Mr. Proper or to Chair or Director Rich is, why does PEB think that this implementation was so poor or went so badly? And, kind of what caused this horrible process?
Laura Rich for the record. I think I can take that, and if Mr. Proper wants to add anything to my response, but I think I can take that. So I'll just explain that we were, PEB has been with LifeWorks for, I think prior to this, easily 15 years, if not longer. And so if the board recalls, this was our first of, I think now 16 RFPs that we've done in 2 years. And there were a lot of factors at play, but Part of this was a response to going out to RFP, was a response to the audit, the LCB audit that found, that had some findings about our contracting practices in the past. And so this was the first RFP that really had to go out, and it was rushed. I will admit it was rushed. It was something that we knew, PEB knew that we at least needed a year for implementation. Really, it was probably longer, and now for sure we know it is. We require a longer implementation period. But because of the time constraints, we literally just recycled the RFP. We updated the previous RFP that had gone out, and so we didn't know what was out in the market, and we expected this was a product that, if LifeWorks could, at the time it was Morneau Chappelle, provide it to us, why couldn't other organizations out there? So we went out to bid, and we presented things in the RFP that we felt pretty accurately captured what our requirements were. And so I think that those who responded, I can't remember off the top of my head how many responses we had, but I think we had at least 3 or 4, probably 4, I think. So the responses did include, responses to all of our requirements and agreements to meeting those requirements. I specifically remember during the RFP or the implementation kickoff meeting, we were in the middle of COVID, and things had been shut down. And so one of my questions to LSI and Benefit Focus was, we're in the middle of a pandemic. I understand, we're closed down in a typical IT transition situation like this. We would, you'd bring in your team, you'd sit with PEB staff, you'd identify business processes and, and do a gap analysis between what your off-the-shelf product does versus what PEB needs. Given that we are facing, the COVID situation, PEB made the offer that we would accommodate if they did want to bring folks into the office, that we would accommodate that and wear masks and just accommodate those the circumstances that we're being faced with. But they did indicate that they could do this remotely, and that they would interview staff and share screens and things like that, and that this could be done remotely. I think what ended up happening was that staff, they did sit with staff, they did interview all staff, they figured out, the processes. But I think really where this failed is that they interviewed staff and asked the questions that would fit their off-the-shelf product, but they didn't identify the areas that PEB was currently responsible for that did not get addressed in their off-the-shelf product. And so basically that gap analysis was not done. And so they got the answers they needed to fulfill their what their off-the-shelf product could perform, but they didn't identify what was missing, essentially. And so, as we got closer to go live, and we kept asking about billing, and we kept asking about invoicing and what's going on, and why is this, this is to us, this was a very major function of our system. And it just kept getting dismissed. And so I think it wasn't discovered until the 11th hour that there were some assumptions made that, okay, well, normally industry standard, clients don't need what PEB needs. And the complexity of the accounting and the reconciliation to, even though it wasn't the RFP, the reconciliation to specific pay centers and things like that. So that effort was determined to be much more complex and intense than the vendor had originally anticipated, and that wasn't discovered until the 11th hour. I think the fail there was it should have been discovered on day one had a gap analysis been performed. So that's, I mean, that's my opinion on, you know, where this where this was missed potentially. We know that going forward that we have a system that obviously is customized and built for PEB specifically, and it is not industry standard. So moving forward, we'll probably do an RFI, and then follow up with an RFP, and take our time doing this. And so there's been a lot of lessons learned throughout this period. And fortunately, with this option that staff is recommending, we do have the ability to take our time and to really vet any new system that is implemented versus the time constraints that we had previously.
I see that Member Woodward has a question.
I just wanted to clarify, you are recommending option number 3. Did that include the issue with invoices and such either being reimbursed or not being reimbursed, that type of thing?
Nick Prober for the record. Yes, option 3 includes billing and invoicing components.
Member Aiello?
Tom Verducci for the record.
Okay, Mr. Verducci, I'm going to ask you to hold on because Member Aiello had her hand raised, and then I'll go to you next.
Thank you.
Just a quick question. So with the billing not going to our members, those members that have chosen voluntary benefits, are they getting them? Do the vendors know they belong to them if they haven't been billed and paid, or are they not getting their benefits? Or, I mean, if they needed them?
Nick Prober for the record. So not everybody in voluntary benefits is in a direct to build status. Most are payroll. Like if you work for NSHE, if you're a PERS retiree or work for central payroll, those are payroll deduct. And of the members enrolled in voluntary benefits that are direct to build, the volume is a little over 400. They have not received any voluntary benefits direct build, but I received confirmation from Benefit Focus that their policies are in effect and have not been canceled.
Okay.
If that is not the case, I mean, I've been asking for updates on that regularly. And this last update was over a month ago, so hopefully that is still the case, as I have not heard otherwise from Benefit Focus.
Okay, because I mean, virtually then they're not getting a voluntary benefit if they have been canceled. But
okay, Member Verducci, and then I'll go to Member Kelly.
Well, thank you, Tom Verducci for the record. So my question is, what is LifeWorks doing differently than LSI that would solve the billing issue in terms of processing the payments, and what are the difference between the two firms in terms of having a process in place that resolves this billing issue?
Nick Proper for the record. So LifeWorks was our prior vendor, previously known as Morneau Chappelle. And so their billing solution was a complete closed loop billing solution. This includes adjustment files and reconciliation files that show how much a member should pay, how much they actually were deducted, and then if they need a refund, what that would be on future adjustment files. So it was completely set up and integrated correctly with all agencies and carriers, as opposed to the current path, which there are not adjustment files and there are not reconciliation files. And we don't even have a billing platform to begin with, but aside from that, just the processes are not there. And to get the full processes and functionality we need with LSI and Benefit Focus, we're at least a year out. So what would we do in the year interim going down this path? We don't know.
So just as a follow-up, prior to implementation, was any of these issues discussed with LSI, or was this post-contract implementation?
Nick Proper for the record. So before go live, nothing was actually discussed with LSI. LSI was not involved in any of the meetings or integration calls whatsoever until go live, when, okay, now things aren't working, better get involved now. We did have preliminary talks with Benefit Focus, but every time we requested billing calls or billing information, it was always from Benefit Focus, we need to circle back internally, we'll get back to you, we'll get back to you. Well, now it's go live, and now we're at where we're at.
This is Laura Rich. I do want to add that staff on at least 2 occasions brought concerns to me where I elevated them to LSI leadership and Benefit Focus leadership and had calls on the concerns with the leadership. And both times, and this was prior to go live, and both times I was assured that all resources were being directed towards this project, and that go live would be fine, and that the risks involved were minor, that everything would be fine on January 1st.
So do we know that LifeWorks is willing to put the resources forward to make this successful and resolve the issues that have led to this? There have been discussions with LifeWorks with a plan of action that's going to resolve the mess that we're in right now.
So Laura Rich, for the record, we actually have representatives here from LSI, from Benefit Focus, and from LifeWorks. I don't know if Paul or David from LifeWorks, if you would like to address that question specifically.
Sure. This is Paul Solich from LifeWorks for the record, just to kind of answer your question. So we've been essentially thinking through the process to be able to catch up to present. One of the pieces that is important to understand is we have the data available on our backups. So when you talked earlier about reconverting the data, back from Benefit Focus to LifeWorks, that's not actually exactly how we would do it. What we would do is restore that data. So folks like, I can't remember who it was, I think Michelle Kelly mentioned, she hasn't changed things for many years. So her data is actually going to be just fine. And there's going to be the vast majority of people that really haven't had a demographic change. There will obviously be new hires. There'll be people terminating, people changing pay centers, people changing address. Those kind of things will happen, but it won't be the vast majority of the population. There'll also be people making benefit changes, having children, changing tiers, those sorts of things. So our plan, really high level, is we restore things to the way they were at the end of last year. We have essentially 3 months of catch-up work. So what we would need from Benefit Focus is a list of what are the transactions that have actually been made in the system to do with demographics, to do with benefit changes, to do with dependents. And that information will have to be reloaded into our system. We'll sort out how to do that. Some things can be done automatically. Some things are better done via human resources. So we've talked a little bit about doing some staff augmentation to support the catch up for a lot of that activity that have occurred. From a billing reconciliation perspective, our system was built on the context of being able to support a closed loop payroll environment. And back when we implemented PEB originally, we had that ability to do closed loop payroll as well as to do group-based invoices as well as individual. And that's something that we grew into because we were doing public sector and multi-employer clients as well as traditional corporate type clients within our platform. So all of those billing capabilities still exist as they were. There will be balances for people as at the end of the year. And what we'll need to do from a catch-up perspective is essentially replay history as if it had occurred in our system in the first place, meaning, run the regular payroll file schedules, run the regular invoices. The PEB staff, carries folks from a payment perspective. They'll be able to upload batches of payments that have been received from the various different paying agencies as well as individuals. We'll need to load data from central payroll, from PERS, from NSHE, to be able to simulate the environment of actually us kind of operating in real time over the last 3 months. The goal, of course, then is by the end of the time that this reconciliation has occurred, things will have been played out in our system as if they had never been taken from the system. So that's kind of the high level plan. It's obviously going to be a joint effort. It's not just LifeWorks on our own. It's LifeWorks, it's the PEB staff, and I think we'll need a bit of support from some of the agency reps, because if you don't trust the demographic feeds that have been coming through, you might want to actually have the agency reps' eyes on the data to make sure that it's actually clean by the time we turn things on for open enrollment. So that's kind of our high level plan that we've been working through with the PEB staff.
Okay, this is Laura Freed. I think what I'm going to do is try and keep the focus. Thank you, Mr. Solowich. I apologize if I butchered your name.
It's fine.
I think I'm going to keep the focus on board member question time for staff, and then I'm going to have board member question time for vendors. So with that, if you don't have a follow-up, Mr. Verducci, I'll go back to Member Kelly if she has another question of staff.
Thank you, Chair Freed. So my question, I'm going back to the voluntary benefits, because I seem to recall that one of the big, I think, talking pieces about benefit focus from, when we became aware of them was that they would, PEB would be getting out of the voluntary benefit business, all of the contracts and whatnot, because benefit focus hold all those contracts, and we'd kind of just be dipping into their playing field, if you will. And so, of course, during, the special open enrollment, a lot of voluntary benefits were actually offered. So if we revert to LSI per the recommendation, who is going to be contracting with all those voluntary benefit providers? Who's going to hold the contracts? Are we getting group pricing? Are they going to maintain the pricing? I think obviously when you offer these products, as you all know, they're kind of, employees bank on kind of the price they're offered at, and that it's an employer program. And it sounds like maybe not. So can you talk about that, Mr. Proper, please?
Nick Proper for the record. So many of the voluntary benefits that are currently offered were previously offered with LifeWorks, and they used their broker CoreStream, and that would continue if we go back to LifeWorks. So their broker is CoreStream, who's licensed and in good standing to continue to administer all voluntary benefits. So PEB will not be the broker and not be directly administering them.
Laura Rich, for the record, PEB actually got out of the voluntary benefits game many years ago when we did this with LifeWorks originally. So we initiated that original voluntary benefits platform through LifeWorks. And so when Benefit Focus took over, LSI and Benefit Focus took over, it then transitioned to essentially a very similar platform, just through a different vendor. But they do have the same carrier relationships and things like that. And so a lot of the contractual relationships that CoreStream would have is very similar to what Benefit Focus has with the carriers as well.
Okay, I am not seeing additional questions for the PEB staff. No? Okay. All right. With that, I think I will ask a question of LSI, because Member Biddleston had said during her question to Mr. Proper that, her impression, and mine too, was that LSI has asked us to pay for all of these change orders. I saw Mr. Muir shake his head. So, Mr. Muir, is it not so that you would like PEB to pay for these change orders to fix things?
Yes, sure, Chairman Freed, thank you for that question, and Scott Muir for the record. So let me answer that specific question. I'm going to go to the PEB staff board report here, and I'm going to talk about items 2 through 6, which Mr. Proper talked about. And I believe, and Mr. Proper can correct me if I'm wrong, those were all approved via an amendment in the contract that was approved by the PEB board and signed off, I believe, on January 3rd, as agreed to. And we have been working through those diligently as we've gone through and tried to understand all of the requirements, make sure there's a quality fashion to delivery. And I agree, some of this has been delayed as we keep turning over new further and further requirements. But as I sit here today, of those 5, and I'm looking on the late, and I know that this is a little dated between when Nick sent in his report last week and today, but everything I'm looking at from as we sit here today is either in working or by 325, which I believe we've conveyed, all of the remediations have been or will have been put in place to solve the outstanding issues that Mr. Proper has.
Okay, wait a minute. Mine was a yes/no question. Are you asking the board to pay for these change orders? Yes or no?
I didn't know it was yes or no. Yes, Scott Muir.
Okay. All right. And I'll go to Mr. Proper now to explain to us how that relates to contract amendment. And if there was a scope change to accommodate the Smart 21 delay in its payroll wave rollout. And so go ahead.
Nick Proper for the record. I'm not too familiar with the contract terms and the scope of what's been approved and whatnot, but that LSI work order for the Smart 21 delay, that's news to me. The other estimates we were provided before, but they're not working. Bottom line, they're not working. So you can ask us to pay whatever you want, but they're not working. All these remediation efforts have not worked and continue to not work. I have verbal and written confirmation that on many of these, we're going to require future work orders. Everything presented in my report is completely accurate as of today, right now in time.
This is Carrie Eaton for the record. I can address the amendment. The amendment was just adding additional work order authority to the contract. It was not approving any change order or work orders. There was a change request for change orders that did outline all of those, but as far as I know, that was never signed or approved.
Okay, thank you. Board members, questions that you might have for Benefit Focus, LSI, LifeWorks? Member Verducci, and then I'll go to Member Biddleston. Thank you.
Did I hear earlier in this meeting, is the former executive officer of PEB employed with LSI?
No, sir. He is employed with Benefit Focus.
Yes. And do you know if the individual receives commissions on these products with Benefits Focus?
I think I'll go to Ms. Winters from Benefit Focus to field that one.
Well, Chairperson Freed, I'll speak because the contract's under our name and Benefit Focus is our subcontractor. I can confirm to the board that individual does not have anything to do with this project. We went through a complete vetting process when that was brought up last year to the PEB staff, that person would not have any involvement in this contract and does not receive any new compensation as a result of the PEB revenue or PEB contract that we have.
Okay, thank you. I was just trying to determine if there was any conflicts of interest that exist. So appreciate you answering the question.
Yeah, okay, fair. Mm-hmm.
Member Biddleston.
Thank you, Leslie Biddleston for the record. This is directed towards LSI. So I mentioned in my question to staff earlier about, products off the shelf, and we realize that, sometimes, we need to make some changes. So I'm just trying to reconcile what I heard from Mr. Muir and Mr. Proper. Mr. Muir is saying things are working and Mr. Proper is saying things are not working. So my question to Mr. Muir is, let's say, how many more change requests are we going to need? So if we test something and it doesn't work, how much more do we have to pay to make it work? How many more change orders are we going to need? Because we can't just be in this cycle of we don't know with people's benefits. And, so I guess I'm just trying to reconcile with what you're saying with what Mr. Proper's saying. You're both saying two different things. So I want to hear from you, Mr. Muir, on what your thought is going forward on that whole thing.
Thank you, Board Member Biddleston, and thank you for the opportunity. I think it would, before I get to the final answer, I think it would be helpful for me to give the board some context. As we sit here 16 months later, we have not, while we have billed a few things, PEB has not paid a single dime for this contract, number one. Number two, outside of and I'll talk about the Central Payroll Advantage, the big change order, and I'll explain where that came from here in a minute. But all of these other ones, ESI, HB, Willis Towers Watson's, it was outlined as normal, sustaining work that needs to be done as you all change your file specifications, your benefits, your structures, and all that kind of thing. So to answer your question, and I will also mention that as it results to fixing billing or getting PEB to a good place on billing, and all of the work that we've done in 2.5 months to fill in all of the custom elements that, as Executive Rich had mentioned, are outside of the the normal or best of breed off the shelf product, we have done on our dime, and there is no intent to change or to charge PEB for that. As a good partner, we recognize that we could have done, like all of us could have done, better in discovery, better in preparation, better in go live, but we are where we are. We're 16 months or 15 months into this thing, and we are committed to delivering what we said we were going to deliver. I would like to correct again for the record, it's not another year to get billing live. I will agree with Mr. Proper that we in the 27th board meeting came to you and said we will have billing live. We have a plan to go live by, I think it was the 14th of February, with new requirements and new functionality that we discovered. I'll take the ownership for that. We put a proactive plan in place with PEB on February 11th, and we showed them a complete runway to get them everything they wanted except this closed loop. And it's really a financial management engine sitting inside of a benefit solution. And so we said, we can get you live. Here's the step-by-step. And we, by the way, have been executing against that plan with the complete visibility of the PEB staff. And we are confident, we just had a meeting this week. We are confident that on April 18th, we are going to deliver, outside of the financial management engine, the entire group and direct and consolidated billing functionality, and in a fashion that does have customizations specific to PEB without any other further charges. So I just want to get that on the record. And I also want to get on the record that we just had a meeting this week where we have put a tremendous amount of effort to ensure PEB's open enrollment on 5/1 as planned. And we have provided a detailed, step-by-step plan, remediation, risk mitigation, the whole 9 yards to ensure that PEB goes live with open enrollment as planned 5/1 with no additional costs. So I just want to make sure that everybody, my job here is to give you context and information from our perspective and a commitment that we're not giving up. And this is a function, in my opinion, of two factors, primarily. As Director Rich mentioned, PEB is a very complex organization. It has been on a 16-year-old system that we can debate whether it was designed for them or not, but it sure looks like a lot of that functionality inside of that product was designed for PEB, that we're now having to go back and try to form fit into a best of breed solution, which we're happy to do to the extent we can. We've also said that from a best practice perspective, the financial accounting should be in a financial accounting module. And we have recently stepped up and said, we are willing to provide that. It will take us a little time to get there, but we're not running away from that, because it's our belief that that should be in a module that is truly built for financial accounting and be integrated back to the benefit focus platform. So I know there's a lot of frustration. I get all that. I think the other thing I need to say is that we are working through two major transformational projects here. The PEB project is concurrently going on with the Smart 21 project. And on top of all that, we've had to sit in the middle with interfacing back to the state's legacy payroll system. That in and of itself has caused all sorts of challenges, which, by the way, my team at Benefit Focus has stepped up and did everything we could to keep band-aiding this thing together until we can get to Smart 21. Because when we get to Smart 21, a lot of these issues are going to go away because of the functionality that's sitting inside of that payroll system versus what we have right now. And I have to state also, because I'm concerned, if we're talking about the limited PEB staff and it's already big workload, you've just heard you want to go back to rekeying in everything from the HR system of record into a separate system because you all don't trust the integration. And the reason why you don't trust the integration is because we're in the middle zone between the old world and the new world. And I don't think that it's realistic to think that that PEB is somehow going to flip a switch and go back to a vendor that you all went to RFP on for a reason. I'm guessing because they weren't providing you what you needed, and you wanted to move into a more transformational position. So I just want to reemphasize, if we're talking about all these as problems, then I would look at this as a cause situation and put it out so that I didn't have an ability to respond to the staff recommendations. I'm happy to, and I'm not going to, it's not a back and forth. I'm just trying to give you guys real world data that sits here today for you guys to make an informed decision, and also commit, we are not running away from this thing. And it would be a shame to flush away 15 months of effort as we've all learned together how to get to the other side. Hopefully that helps.
Member Biddleston, do you have a follow-up for Mr. Muir before I ask Mr. Prober to discuss those comments?
Yes. So I have a follow-up. So Mr. Muir mentioned that, he was making some changes all on the dollar of your organization. So now I'm back to, what are all of those change orders for? Because there are almost $500,000 in extra charges. So I'm trying to, in my own mind, figure out what you're talking about.
Sure. Yeah.
Thank you.
Yeah. So Chairman Biddleston, let me before we go to, I want to let Nick chime in here as well. But let's talk about the big one, the 261,424. So this is the function of, there are two separate contracts. Even though we as LSI own both of them, they're not the same terms. They are not the same objectives. They are not necessarily the same structure. Yes, I'm trying to bridge as the program director the best I can between these two, but I don't control, like Nick said, he doesn't control Smart 21. I don't control Smart 21 at the state level. I'm relying upon the Smart 21 Executive Committee to give us direction and guidance. And I think Chairman Freed can confirm with me with that the delay in the Smart 21 payroll was a joint decision that was made, I think officially, I think it was preliminarily made somewhere in the October timeframe, but officially made in the late November, early December timeframe. And so there was a need. We had to do something to get PEB live because the goal we were up against, PEB was turning off its previous provider on December 31st, period, end of story. So the goal that we were presented is you got to provide us a way to get to go live. And the only way to do that is to build this interim interface. And that's what you see here, right here. And we did it at cost. We're not trying to gouge anybody. We did it, by the way, we did it in 2 months. That should have taken 4 months. We did it in 2 months with all the people we had to throw at it to allow us to meet the contractual goal of getting PEB live on January 3rd, as requested. So I'm not sure how to bridge this one because I didn't control necessarily. It wasn't our holistic fault that the Wave 1.3 payroll for Smart 21 didn't go live on January 1st. It's now going live on July 1st, 2022. And I get that PEB is not necessarily, in control of that either, but that contract said we had to go live on January 3rd, and we did. And so that's where that one comes from. The other ones, and I'll speak to Carrie, all of these were outlined in the amendment. And these are normal sustaining when we go into file specific customized file integrations. This is the work effort that we had to form fit those files to meet PEB's requirements, PEB's rules, the carrier's obligations, because we all went into this with the concept, and it's in the project charter. We're going to try to use best practices, standard integrations, because from a sustaining point, that's where you want to get to. Unfortunately, and that's okay, PEB is complex. So we're trying to accommodate all of this stuff on the fly. And that's where you see these change orders coming from. And again, there's some updates. I'm not trying to accuse Mr. Proper of incorrect information, but there's some updates that, no, there are no more. You don't have to go pay HSB $10,000. Those kind of things. So we're trying to mitigate all these down to everything that we can to make this right by PEB. So hopefully that helps.
So, Member Biddleston, if you have anything else to add, please do.
Yeah, one last thing. I hear Mr. Muir talking, but I heard earlier that LSI has both contracts with Smart 21 and with this. And Mr. Muir said just a few minutes ago that it was not his fault. Okay, maybe it was not personally your fault, but wasn't it LSI's fault? So I guess I'm just trying to figure out, why the right hand isn't talking to the left hand. So I don't know if that's a question or a comment. It's just trying to figure it out.
Right. Well, since Mr. Muir invoked the Smart 21 Executive Committee, I guess I'll weigh in on that. We did decide to push the payroll wave back after a lot of debate at the Executive Committee. And that was because payroll, otherwise known as Wave 1.3, among those who mess around with Smart 21, wasn't getting as far as it needed to get because Wave 1.1 and 1.2 didn't have the functionality they were supposed to have. So, and also it's, the Executive Committee did make that decision last fall, but it's also not the Executive Committee of Smart 21's job to inform PEB, and it's LSI's job to inform PEB, and I don't think PEB was informed timely that that was pushed back and it would have some effect on their E&E system. And to the idea of being asked to pay for change orders, I started going back because board members, I know you all weren't here when we approved this contract. This was approved originally at the November 23rd, 2020 board meeting. And the staff report at that board meeting gives the requirements for the minimum functionality of the system. The high level function, and I'm reading here from the staff report, and I promise I won't bore you all by reading for 15 minutes because it's a lot of bullet points. The high-level functionality of the system should include, at a minimum, but not be limited to, a solution providing core line of business functions, which include applications that permit the agency to perform operations, including determining member insurance eligibility in accordance with PEB's eligibility rules, provide a sophisticated eligibility rules engine with automated solutions that increase efficiency in administration of the plan, call center management tools, facilitating benefit enrollment, including transfer of data from and to other internal systems, employers, and third-party administrators, updating and maintaining coverage records, the capability of billing premiums to multiple employers and pay centers, generating direct bills to all participants, including COBRA participants, and to administer all accounts receivable and payable while also being able to reconcile invoices with incoming payments. And then it goes on and on, actually, for several more bullet points like on an entire page. So, you know, I'm perturbed that stuff that was in scope, I mean, and the staff report comes directly from the RFP language. So stuff that was in scope, we're being asked to pay for just to make it right. And it's nice that PEB hasn't put out a penny for this. And just last meeting, we assessed, you know, a penalty, and that's all nice. But we've had now since the beginning of January, a member experience and a PEB staff experience that isn't what it ought to be. You know, I've received complaints. I think other members of this board have received complaints. The governor's office has received complaints, and I know PEB is buried, and central payroll staff has received complaints. So, you know, I'm concerned that things that I thought had been fixed, like the PERS deductions from retarees for their premiums, turns out not to be fixed.
Can I speak to that, Chairman Freed?
Yeah, you can.
This keeps coming up, and again, I'm just trying to be objective here. To your point, this PERS deduction file, we just ran that one down, and again, here's a situation where we coded to what we were told, what was required, and then all of a sudden we get back from PERS. Oh no, wait, you got to do it this way, and codes that were not in our system or in our scope that we had no visibility to, we had to, you know, accommodate. And again, I just want to say it for the board. We didn't squawk, we didn't yell, we didn't try to create a change order right away. We said, okay, we'll go fix that PERS, and we just did. So again, I get the frustration of PERS, but this is an example of we all agree to a specification, and then we find out there are new requirements, and that's really where these change orders are coming in. Outside of number one is where these change orders are coming in. And so I want to say a couple other things. These change orders are not surprises. They were all outlined, and I think you guys reviewed these, because I can show you the documentation in the documentation that we had, where we outlined here's what the scope is of these change orders, here's the cost, and I have documentation from PEB that these were all approved. Now, some of them, to my point, haven't been yet all fully delivered, to Mr. Proper's point, but it's not like we're creating new work to say we're just going to keep billing you and nickel and dime you, because that's not what this is about. And I just want to, and Chairman Freed, with all due respect, PEB was informed officially by OPM in the summertime that there was a possibility that wave 1.3 was not going to go live. And that was the responsibility of OPM, not LSI. And number two, it was not necessarily what was happening with 1.1 and 1.2, as you recall. It was a collective agreement on the move from 1.3 on the resource availability, the readiness of both organizations to effectively move wave 1.3 to July to be as successful with that massive transformation as possible. So I just want to make sure that's my point for the record.
I'm going to go to Member Kelly now.
Thank you, Chair Freed. I guess I'm still, you know, I think I'm doubling back to Board Member Biddleson, because I still am not clear. I think Mr. Proper was really very specific in his list of items that are still not working. But then I heard Mr. Muir say, that's not right. Everything's been fixed, but not specifically. And so I just wonder, Mr. Muir, if you can address specifically the items that Mr. Proper talked about not working and still not working, and yet you're saying it's all working. Like, to me, that's obviously a huge disconnect. So can you perhaps be more specific in your response? I'd appreciate it.
Chairperson Kelly, and I will submit this for the with the committee. Again, I want to be respectful of Mr. Proper. We haven't had a chance with everything going on to get him this information, which is relatively up to date, or just coming up to date. So there are 5 items on the list. The custom ESI file, which is item number 2 on their report, it says is dependent upon the HSB file integration below, which I'll speak to. The custom HSB file, which is item number 3, it says the dependent care management records are being sent to Benefit Focus. When Benefit Focus turns around and sends the dependent record to HSB via the 834, employees are not referenced. This is because care management benefit type has a dependent only plan. Configuration resolutions are being tested, meaning that my Benefit Focus team has proactively gone in there and understood the problem and now is remediating that and testing that to go back to PEB and say, all right, we fixed this and we understand it and we're fixing that. So that's actually the HSB and ESI files. On the Willis Towers Watson HRA file, number 4, it says the production ready file is to be delivered on 3/25. When I say for the board, production ready file means we've gone through all the unit testing. This is a thumbs up fix. And so it says production ready file to be delivered on 3/25 to ensure the counts, format, and logic are accurate. On item number 5, which is the Willis Towers Watson eligibility file, again, same thing, because they're kind of tied together. Production ready file to be delivered on 3/25, and that will ensure all of the remediations. And then the final one, item number 6, custom Medicaid file. So here's the update on that. File has been live since 2/3/2022. That said, we are applying an update to send PEB ID, which was a requirement that we got, with a leading 0 when dependent SSN Social Security number is missing. This was a new requirement surfaced after initial requirement sign off, pending PEB's sign off on the requirements. So again, dug into this one. This should be fixed in the next update to this file, and it will incorporate the customized requirement of having to send the PEB ID when the SSNs are missing. So that's hopefully that Chairperson Kelly, hopefully that helped.
Okay. Mr. Proper, have you any comments, sir?
Nick Proper for the record. There's a lot of things I want to say, but I'm going to try to keep it as simple as possible. If everything was working correctly, we wouldn't be having this discussion right now. This wouldn't be a board agenda item. We would not be recommending to go to a prior vendor if everything was fine, as Scott explained. It's just not true. There's a difference between something that should work and is working. Big difference. He validated every single point that I stated, that the files are either testing or in a testing process and currently not working.
Okay. So I'm sorry. Did I talk over you, Mr. Proper? Okay. So let me move the discussion then to the consideration of the options. So a question for Mr. Proper or Ms. Rich. I know we have a solicitation waiver in progress with purchasing if we were to go back to LifeWorks. The way I'm understanding what was described from both PEB staff as well as the LifeWorks staff is that we would be essentially turning back on the old E&E system, and the challenge is really catching up with the data from the end of December to now and making sure the demographic files are right, because the file transfer processes are all in place. Is that a correct understanding?
Laura Rich, for the record, that is correct.
Okay. And how quickly can all of that be accomplished?
Laura Rich, for the record, we need to have this accomplished no matter what by open enrollment, which is why we are delaying the start of open enrollment and shortening that window. it still has to be determined, until LifeWorks gets in and determines what exactly, what the scope of the situation includes, right? It could be that we go live April 15th. It could be that it's not till May 1st. I think that there still needs to be some legwork that's done to determine that, but, worst case scenario is that it needs to happen before open enrollment. And hopefully, at least I would say significantly before open enrollment, if we can make that happen.
Okay, thank you. All right, at this point, I'll ask the board members to give me a sense of where they are with respect to the staff recommendations.
This is Betsy, and I have a question based on something you said, Laura Freed. We have not gotten an approved solicitation waiver from purchasing at this point.
My understanding is that PEB does have an approved solicitation waiver, and Carrie Eaton is nodding yes. So thanks for the confirmation, Carrie. Member Biddleston.
Yes, Leslie Biddleston for the record. I just wanted to restate what I think the recommendations are for my own mind. So basically the recommendations are, number one, to terminate with LSI. Number two, to go back with the previous vendor, LifeWorks. Is that right? Okay, thank you. And the third recommendation is to begin work on an RFP for 2 years from now or something like that. I just want to make sure I understand what is being recommended.
Laura Rich for the record. In addition to that, we are also recommending that the delay of open enrollment from May 16th to May 31st. And I would also, just based on the information that we've learned in the last week or so, that RFP probably needs to start out with an RFI.
Okay.
Chairman Freed, can I ask the board a couple of questions I have before you? I think you're heading to a decision here. Can the board define when you say cancellation, what type of cancellation are we talking about? Are we talking about a termination for convenience or a termination for cause?
Mr. Muir, this would be termination for convenience.
And I'm sorry, the other question is the PEB option 3 take into account that there is nothing built into the Smart 21 plan as we get to final testing now to accommodate this change by PEB, thus potentially affecting the go live date of the Smart 21 Wave 1.3.
Yes, this is Laura Freed for the record. I believe PEB and OPM have had discussions about this already.
Okay.
Okay, board members. What y'all thinking?
This is Leslie. I'll take the lead on this.
I was gonna say I'm gonna have to start, calling people out by name. But so thank you for that.
You're welcome. So this gives me zero pleasure because we want everybody to be successful, but also we have to think about our members. So I think that we should adopt the recommendations of the staff, which includes the termination of the contract with LSI, the picking up with LifeWorks, delaying the open enrollment, and then starting the RFI and RFP process. And like I said, this gives me no pleasure. The whole situation is just downright depressing and sad. But we as the board have to think about our members, and we have thousands of them. It's not like we're dealing with 300 or 400. So that is kind of what I'm thinking, Chair Fried. So those are my thoughts.
Thank you. Other board members?
Fried, could I just to clarify, the recommendation is to not pay the invoices as well. So I'd like you to make sure that that is part of whatever motion gets made.
Okay, got it. Understood. That was Chief DAG Michelle Briggs for the record. So.
Do you want me to make a motion, Chair Fried? Because
yeah, you bet.
Okay.
Go for it.
All right, let me attempt to make this motion because that's kind of complicated. Okay, I move that we as the board terminate the contract with LSI, not to pay the invoices, pick up with our old vendor LifeWorks, delay open enrollment per staff recommendation, and to begin the process to do an RFI and an RFP. I hope I got everything.
And that's termination for convenience, correct, ma'am?
Oh, termination for convenience. Thank you.
Got it. Okay, so that's the motion. Do I have a second? Second from Michelle Kelly. All righty, board members, you've heard the motion. Any final questions or discussion on the motion?
Chair, this is Carrie Eaton for the record. I just need a clarifying question. When the motion says not to pay the invoices, I want to make sure, is that only the change order invoices or any invoices for PMPM and COBRA as well?
Sorry, this is Leslie. I will amend to not pay the invoices per staff recommendation. Does that work?
I would say specify in the motion the work orders that are presented in the staff report.
The work orders presented in the staff
okay.
report.
There we go.
My apologies. That was a complicated one.
No, that was good.
My brain.
Thank you for the clarification. It's important to get it right.
Chairperson Fried, I obviously the decision has been rendered. I just want to say two things. Totally respect that's your process. Very disappointed that we're down this road. Really believe this is the wrong decision, but that's your decision. And I'm going to put this on the record that we will protest the payments because that is work delivered. So we'll take that up with procurement.
Okay. So board members, let me recap the motion. It's been moved and seconded to not pay the work orders that were presented to us in the staff report, terminate for convenience with LSI, and pursue a solicitation waiver with LifeWorks, the previous vendor, release an RFI and ultimately an RFP for a new E&E vendor, and shorten open enrollment from May 16th through May 31st of 2022. So that is the motion on the floor. And now I'll call the question. All in favor, signify by saying aye. Raise your hand in your little box. Aye. Any opposed, say nay. All right, motion carries. Thank you very much, everybody. Let me make a little note before we go on. Okay, so we will move on to agenda item 8, which is our usual contracts item, and I will hand it over, I think, to Ms. Eaton.
Thank you, Carrie Eaton for the record. Item 8.1 is an overview of the current active PEB contracts, and there's no action necessary. So I will move on to items 8.2.1 and 8.2.2. They are requesting that the board approve new contracts resulting from the March 25th, 2021 meeting, where the PEB board approved staff to release a solicitation for an actuarial consultant and a life insurance provider. The actuarial consulting RFP for item 8.2.1 was released on October 18th. On November 29th, PEB received 3 proposals. The 5-member evaluation committee that included 1 PEB board member and other subject matter experts chose Siegel, as the winning vendor. Siegel will be a new vendor for PEB, so some disruption is expected. However, transition work has already begun to ensure Siegel is properly briefed and prepared to begin work on July 1st. Staff is recommending that the board ratify and approve the evaluation committee's recommendation to contract with Siegel for actuarial consulting services beginning July 1st.
This is Bethany. I just
Sorry, I was catching a member yellow.
I'm sorry. I just have a question. It says services and fees are expected to begin on June 1, but you're saying July 1, is that?
That must have, this is Carrie Eaton for the record. That was must have been a typo in my report, July 1st.
Okay.
So board members, do you want to take all the new contracts in one bunch, or would you prefer to act on all of them independently?
I think taking them all in one bunch.
Okay, thank you.
This is April.
Cool, thank you. All right, let's move on to the next ones.
Okay, Carrie Eaton for the record. The basic life insurance RFP for item 8.2.2 was released on October 14th. On November 8th, PEB received 6 proposals. The 5-member evaluation committee included 1 PEB board member, and United Healthcare was chosen as the winning vendor. United Healthcare will be a new vendor for PEB, so some disruption is expected. However, it is expected to be minimal. And staff is recommending that the board ratify and approve the evaluation committee's recommendation with United Healthcare for basic life insurance beginning July 1st. Item 8.2.3 is requesting the board to approve a short-term service contract. PEB IT staff is upgrading the PEB boardroom with technology to accommodate future hybrid in-person and virtual meeting solutions. The equipment for this project is being purchased through the state purchasing requisition process. However, because the equipment will need to be installed professionally, PEB is required to enter into a short-term service contract to allow Vivo Tech to install equipment on PEB property. The total cost of the services for this contract are not to exceed $6,480. And the last one, item 8.2.4 is necessary as the board voted to approve option 3 and item 7 from the Enrollment and Eligibility System Implementation Update Report. PEB staff has an approved solicitation waiver to enter into a new contract with LifeWorks Ltd. To turn on our previous eligibility enrollment system. PEB is still in the process of negotiating this contract for a 4-year term. And so staff is recommending the board ratify and approve all 4 of these new contracts. And I would be happy to take any questions.
Board members, questions on 8.2, any of them? Okay, hearing none, I will accept a motion to ratify and approve the evaluation committee's recommendation on 8.2.1, 8.2.2, and then ratify the contract with Vivo in 8.2.3, and then the contract with LifeWorks in 8.2.4.
This is Leslie, so moved.
Thank you. Do I have a second?
April Kern, I'll second.
Thank you. All in favor, say aye.
Aye.
Aye. Any opposed, say nay. Okay, motion carries. All right, we'll move on to contract amendments, 8.3.
Thank you, Carrie Eaton for the record. I will take both of these at once, if that's okay. Item 8.3.1 is requesting the PEB board approve a contract amendment to the HealthScope Benefits TPA contract. PEB contracted with HealthScope Benefits for third-party administration services, which became effective February 8th, 2011, and has a termination date of June 30th, 2022. This amendment increases the contract maximum from 62.6 million to 62.9 million. And this increase adds additional authority to pay for the services for the remainder of the contract. The shortfall is likely due to an actual enrollment being higher than the initial contract projected enrollment. And the next item, 8.3.2, is requesting the PEB board approve a contract amendment to the new UMR TPA contract. PEB contracted with UMR for third-party administration services, which became effective December 14th, 2021 for services beginning July 1st, 2022, and has a termination date of June 30th, 2028. This amendment increases the contract maximum from 62.8 million to 65.4 million. This increase adds additional authority to pay for claims runout services for the 1 year after the contract terminates, which was inadvertently left out of the RFP. So PEB recommends the board authorize staff to amend the contracts between PEB and Health Scope Benefits and PEB and UMR to increase the contract maximums.
Question from Member Aiello.
The question would be the same for Health Scope Benefits as what you're doing for UMR. Does it have the 1 year claims run out in it that's needed after, because this says June 30, 2022?
This is Carrie Eaton for the record. I believe instead there is also a run-in provision to the UMR contract instead of adding that to the Health Scope contract, I believe. So there, instead of Health Scope doing the run out, UMR will take the run in for the year.
Okay, so it's being covered that way. Okay,
I believe so.
I never would have thought of it except for the 2 in a row there. You know? Okay.
Okay, board members, what's your pleasure?
This is Betsy. I can make a motion that we approve the Health Scope Benefits and UMR contract amendments per staff recommendation.
I'll second that myself. All right. All in favor, signify by saying aye.
Aye.
Aye. Any opposed, say nay. Okay, motion carries. All right, so Ms. Eaton, do we need to do 8.4? Yeah, we do. I'm sorry. Go ahead.
Carrie Eaton for the record. I wasn't aware that that recommendation was going to be in the previous report, so it's a little bit duplicative, but item 8.4.1 is requesting the PEB board approve staff to complete a request for proposal for an eligibility and enrollment system as the board voted to approve option 3 and item 7 from the eligibility and enrollment system implementation update report. PEB recommends the board authorize staff to complete a request for proposal for an eligibility and enrollment system.
I would be happy to make this motion, but I'd like to add on the RFI in advance of the RFP. So I'd like to move to authorize staff to do an RFI and then an RFP for an enrollment and eligibility system vendor.
Leslie will second.
Thank you. Any discussion or questions on that? Okay, hearing none. All in favor, say aye.
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 Any opposed, say no. Okay, motion carries. With that, we're on to the rates, which is usually the marquee event of the of the March meeting. I feel like somehow it's the undercard now. I don't know.
Chair Freed, I just want to address 8.5 just really quick on the solicitations. I just want to say after I think 16, 17, something like that solicitations, it is with great relief to see that there's nothing there, even though it will be very temporary. So I just want to thank, all of our partners, and, Aon has also been a part of all of the solicitations and the consulting that has gone behind those. It's been a huge effort on and lift on staff and everybody that's been involved. And I don't know if Gideon is still around, but Gideon Davis has been there every step of the way and has provided a whole lot of support throughout this process. And so I just want to thank him as well, because I know it was a huge undertaking for him.
Thank you, Laura. This is Gideon. I'm here.
Thank you very much for that. And thank you, Gideon. It's 12:45. Board members, would you like to take a 15-minute break before we dive into agenda items 9 and 10? Okay, so let's do that. We'll come back at 1 o'clock. I'm sorry, Ms. Huber. Thanks, guys. Come back at 1.
All right. Hello again, everybody. It is 1 p.m. We'll call the meeting back to order and we'll get going on agenda item number 9, our presentation from Colleen Huber from Aon about PEB claims experience and trend. Welcome, Ms. Huber.
Great. Thank you, Chairman Freed. I will share my screen and bring up a presentation regarding what we're seeing today as far as not only PEB's claims information and the update on trend, but then also what we are seeing out in the marketplace, especially as it relates to COVID and what we are expecting going forward. Can you all see my screen? And I will put it in slideshow mode.
I can see that.
Okay, great. All right, and with me today, I have my colleague, Tim Zettinger. So Tim, do you want to highlight the first 2 slides and then I'll take over from there?
Yeah, sure, sounds great. So yeah, we'll kick off what we're seeing on, a trend for, PEB's claim costs over the last few years. So on the first slide, we have aggregate claim costs for each of these different service categories for the last 4 plan years going back to FY 2018 through FY 2021. So in the top subsection of this slide, we have our aggregate claim dollars split by medical and RX that are net of rebates and enrollment for number of employees that are on the plan in each of these plan years. In the second subsection, we have dental. Again, aggregate claims and aggregate enrollment here. When we're looking at trend, what we're really trying to get is, what is the average cost of an employee for PEB increasing year over year? And so what we do is try to normalize the amount of aggregate claims for the number of employees. So in that bottom section where we have claims trend, this is where we're really looking at what is that average employee costing per month in each of these plan years, and how is this trending year over year? And so we have 4 different breakouts. We have medical, we have RX, we have combined med and RX, and we have dental, and then we sum these together.
Did we lose you, Tim? Okay, Tim got kicked off. So I will take over, and then when he comes back on, he can take over back for me. So if you look at the slide, again, to Tim's point, the top part is the TDHP plus the EPO, and then of course the middle is the dental, and right below that is the claims trend on a per employee per month basis. We break it down for medical, pharmacy, combined, dental, and then overall. If you look at the very last line, this is where you'll see the experience trend. So in fiscal year 2019, there was a 7% increase from fiscal year 2018. And then in fiscal year 2020, you'll notice a negative 8% prior year. And the reason why it's negative is due to the claims suppression that really occurred through the March 2020 through roughly about May 2020 timeframe. And then as a result of that, due to the claim suppression that we saw in fiscal year 2020, we see the rebound effect happen in fiscal year 2021 of about a 14% increase. The next slide is specific to your all population. This is a rolling 12-month trend. And I know when we discussed it end of last year in 2021, we were looking at very high trend levels as it relates to the medical side. So if you look at the red line, that's your medical rolling 12 trend adjusted for headcount. Now, there are no changes made for plan design or contract changes, just purely on a headcount basis. But as you all may recall, when we last talked about your trend, we were seeing this uptick at the end of 2021 due to the fact that there was a large claim suppression that we saw in 2020, as well as some plan design changes happened. So we saw the rebounding effect. And when we last talked, we were really concerned because, we were seeing it kind of peak out in November timeframe. And the good news is that we are seeing it come back down to normal levels or closer to levels along your line, your historical trends. So the good news is that we're starting to see this even out of the noise from the COVID claims, both the suppression as well as the rebound effect. So what we're seeing what we think will change going forward, really related to COVID, if you start from the left-hand side and move to the right, if you look at your last 15 to 18 months of claims experience, really we saw the largest impact be on the medical side. Pharmacy side was fairly level and we didn't really see this huge impact. But we saw a lot of lulls and outbreaks between the COVID-19. If you think of different time periods with it, whether it was the Delta variant, whether it was the original Alpha, we saw it kind of be more secular when the COVID waves hit. So then within your claims experience today, you have 4 components related to COVID, the COVID-19 testing. And I know we heard about that quite a bit earlier as well. The vaccine costs, even if the government's paying the cost of the vaccine, there's still the administration cost of it. The treatments for your members, whether they had COVID-19, whether they were hospitalized, whether doctor visits, et cetera. And then of course, the other remaining item would be the suppression of other claims to make room for COVID-19 patients. So keep in mind, if your hospitals are setting floors set aside for COVID patients, that means that they can't fill those hospital beds for other types of treatments. So as we look forward to the future COVID-19 claims, at this point, we're expecting them to be more seasonal in nature, similar to what we see in the flu or cold, and really just kind of more of that uptick really at the beginning and the end of each calendar year, similar to the cold and flu waves that we see. We're expecting to be slightly, either the same or slightly less than previous COVID-19 claims. Just what we saw with Omicron is how much the severity has lessened, less hospitalizations, et cetera. So we're hoping and expect to see that continue on into the future. The next item, if you look at the gray box, is the deferred care. At this point, the fact that we are almost 2 years, or we are 2 years out from the initial outbreak of COVID, this rebound of deferred claims, it hasn't occurred as much as everyone thought it would occur. And so the fact that we're 2 years out, it's kind of to the point where, the markets have started to stabilize, but we're also watching other indicators of increase of treatment through employment levels, cancer costs, and specialty drug pricing. But at this point, we're expecting little to no expected net cost impact in the future due to deferred care. And then the last item is really on the inflation side. I'm sure everyone's hearing a lot about this in the news today, but just the fact that the inflation rates are so high, today's the highest level since the 1980s. And we do see inflation linked to healthcare spending through healthcare wages. So if you think of what it might cost to staff a nurse today compared to what it cost a year ago. So we are expecting the economy-wide inflation to continue to add pressure to medical trends, about 1% each year from 2021 into 2022, and then again from 2022 to 2023. So we are expecting about a 1% trend level, and that's across the nation. This is Ann's book of business, and we'll get into your specifics here soon as well, as it relates to rate setting. This next slide is really discussing the testing and the vaccine costs and how that may impact future costs. At this point, we've seen a waning concern about COVID-19, and the real story is that at this point, we're expecting future testing costs to be no larger than past costs. There's different types of tests out in the marketplace. We've seen, more at home through the government, rapid tests. So there's more options than there was at the start of this. So even if we were to say a 33% reduction in testing, it has a very little impact on your total medical budgets. And again, this is for Ann's book of business, not specific to PEB, but just to give you an idea, if we see testing decrease by 1/3, the overall reduction will be about 0.5% of medical budgets. And then at the same time, when we look at vaccine costs, what we're expecting to be in 2022 and 2023, if you think about the vaccines today, most of your population is already vaccinated with at least 2 shots. Some of them have been boosted 3 shots. So even if your members get vaccines going forward, they're not going to be at the same frequency or the same number as they were historically. So if your member already has 3 shots today, they're not going to need another 3 shots in the next 12 months. So if we see about a 50% reduction in the vaccine cost, that would reduce the total budget by 0.3%. Now, one thing to keep in mind, and this is on the news as well, is with how the government will handle the cost of vaccines, if they'll transfer the cost to the healthcare or if they'll have the budget. But overall, we're expecting that impact to be to little to no impact over 2021, maybe even a slight decrease. So on this slide, this is related to COVID-19 treatments and the suppression of other claims. So if you look at, I'm actually going to go to the right to start first. If you look at the U.S. COVID treatment and claim and deaths, you'll see that there's a high correlation between the number of treatments and the members that, again, this is based on national specifics, not tied to PEB. But if you look at the treatments and the U.S. death, there's a very high correlation and very similar patterns to the actual claims and versus the deaths. Now, if you go on the right-hand side, when we look at employer medical claims compared to deaths, again, the deaths are the same between both slides, but the red line shows actual to expected healthcare costs. So essentially, it's been fairly flat. So what this is indicating that even though the COVID-19 treatments are rising and falling with the different waves of COVID, the other costs fall at the opposite. So if COVID-19 treatments increase, we saw other costs decrease. And so what is happening is you see the stabilization of healthcare claims over that same time frame. So as we look to the deferred care, and if it is going to rebound, again, we did see that deferral of services from that March to May timeframe, and it really when the lockdowns and the providers started providing services again, really was geographic based and really depended on each state and how quickly they opened or didn't open. And so obviously that would directly impact the number of deferred services. But as a result of that, there was a temporary period of above normal costs right after. But after, not considering that we're 2 years past the onset of the pandemic, we feel like at this point, the deferred claims are not going to come back 100%. The healthcare system appears to return to an equilibrium state. Claims are medical claims are directly impacted by employment. So if you think of if your hospitals have staff, if they have beds open, then that's how quickly they will return some of the deferred services. So if you look at the right-hand side, this is healthcare employment is the red line, and then the actual to expected claims is the grayish line right underneath it. So as you'll see, both healthcare employment and claims dropped considerably in that April timeframe. Even if you consider what happened to your providers, a lot of the services that were deferred, some of those offices and providers shut down or provided less services during that time frame. So think of your hips and knees, your orthopedic doctors maybe not fulfilled as many services because of the fact that they were on lockdown. So they may have reduced staff and then they tried to increase staff after the lockdown went away. So that's where healthcare and the claims are directly impacted by the healthcare employment. That's why it's so important to continue to monitor that and to see how that's really happening in the long term. The other concern, of course, is long COVID and what that means now that long COVID kind of replaced other conditions that we saw happening at the same time frame. And so I think that'll have to be closely monitored, especially as it relates to the heart, blood clots, et cetera. So we're continuing to monitor that, as well as for the members who do not get some of the preventative services that they should have, especially as it relates to some of the cancer screening. So that's another item to keep your eyes on, as well as specialty drug costs. And then this last slide and trend is really on the impact of the impact of inflation. Again, healthcare trend is directly correlated to the overall inflation of the economy. Now, keep in mind, historically, healthcare trend was always a couple % higher than inflation, but then at the same time, with healthcare trend, it's slower to integrate. It's not as immediate as some of the other goods or services, mainly due to the fact that provider contracts are normally renegotiated every 2 to 4 years. So we're not going to see a large increase immediately, but maybe in the near future, in the next several years. And so that's why we're expecting a 1% increase from 2021 to 2022, and then the following year into 2023. Are there any questions on the trend or anything related to COVID?
I can't see all the board members, so board members' questions for Aon? Okay. Hearing none. Thank you very much.
Great.
So board members, that was a disinformational item. It sets the table for agenda item 10. So let's go ahead and move to agenda item 10, and I'll turn it over to PEB staff.
All right, Laura Rich for the record. I think I'm going to just start out this report before passing it along to Aon again, because I think they're going to do a better job of going over rate development and how these rates were set. But I do want to just say a few words before we get into this this report. There were, as you just heard, there's obviously we're experiencing significant trend, and we are experiencing just the overall nationally some factors that are kind of an anomaly to what we've seen in the past in terms of high inflation and things like that. And so we're going to see all this in claims moving forward, right? And this is going to be something that is affecting PEB in the long term. So there was no appetite from this administration, just from the beginning, to increase rates. No one wants to increase rates on premiums on members at this time, right? We're already having workforce issues, and pay is a topic of discussion right now, right? And so this is not something, a road we really wanted to go down. However, rates is not just something that PEB, just pulls out of a hat and figures out, this is what we're going to charge this year. It's a math equation, and the math equation is it's composed of many different variables, and so it's math. It comes down to math, and the rates are the rates, and we use Aon to help us with that development, right? It's a very complex math equation with a lot of variables and a lot of assumptions. So originally, I will tell you that these rates did not look this way. The rates that we originally started with were a lot higher. And those were the rates that would have been on any other given year proposed and presented to the board. But understanding the circumstances, understanding the goal of the administration to not raise rates, we went back to Aon and said, okay, how can we look at some of these assumptions and loosen up on some of these assumptions? And so we went through kind of line by line and identified areas where we could maybe loosen up on the assumptions a bit and to make ultimately differences that would bring down those rates. They changed the variables and brought down the rates overall. At the end, we were still looking at pretty significant increases. And so we did what in the past has not been looked upon, or it's actually been frowned upon because it creates a fiscal cliff, sorry. And that is using excess money, excess funding to buy down rates. And the reason that we did this is because we do have excess, right? And we're pretty much, all of it has been earmarked. So we used a very conservative amount, about $3 million, to buy down those rates. And so the rates that you're seeing today are much, much lower than what would have been presented on any other given year. And the reason I'm saying this is because, given the landscape that we're facing and just, COVID and inflation and everything that we're facing today, and especially, in the healthcare industry, there's a whole lot of volatility. And so we're taking a different approach this time in being much, much less conservative than we would be in the past. But the last thing also that we want to do is accrue more excess, right? And so this is it. We've definitely, and you'll hear Anne discuss this, we have basically eliminated the conservatism in rates this year. And I think that just needs to be put on the record and emphasized before we get into this. So Colleen, I don't know if it's you or Tim that is going to take this over, but I will pass it on to you guys.
Okay, great. I think Tim got booted and got put into as an attendee, so I will take over for this. But thank you. Sorry, this is Colleen Huber for the record. So just to take a step back, as we look at rates, and as Executive Officer Rich had indicated, it is a formulaic equation, especially as we look to the different assumptions. So high level, we look at all of your claims data, medical, pharmacy, dental over the last several years. And then of course we complete it based on prior seasonality, claims lag, and trended forward. Then we adjust prior claims and future claims by either plan design changes to contracts. I know we heard a lot of the procurements earlier, PBM arrangements and market checks, and any other projected savings that happened historically, as well as we expect them to happen prospectively. And then, of course, we look at the enrollment based on tier and plan and any type of assumptions needed for utilization or actuarial value. And when we say actuarial value, essentially what we are saying in aggregate, what the plan pays as far as a percent of claims as compared to what the member pays out of pocket. And then, of course, we adjust for any type of enrollment and then load into account your admin fees associated with servicing your account. And then, of course, put on a tier basis. So you have your employee plus spouse, plus children, plus family tiers. And it's all based on your board policy regarding the methodology there. And then the last step would be to add to account the life insurance. Overall, for plan year 2023, we are projecting an increase of 6.6% in aggregate. Now, keep in mind that 6.6% actually includes plan design changes of about 2.3%. But of the 2.3% of plan design changes or enhancements, that's being funded through that's being absorbed by the excess reserves or the cash differential. We did look at your most recent 12 months of incurred experience through November of 2021. We actually looked at paid experience through February of 2022. So to Executive Officer Rich's point about adjusting claims, we used as much information as soon as we could get it. And actually it was the annoying factor to your different vendors asking when data would be ready, because we wanted to take into account all of your claims trend, especially as we are moving away from the COVID adjustments. So for this time period, we are actually really using your recent 12-month experience, since the prior 12 months were really impacted by the COVID adjustments. We did, and also it's important to note, as we looked at this, there was no COVID adjustments going forward. So similar to what we just talked about on the trend in the COVID report, we're not increasing your claims, assuming there's going to be any uptick in COVID costs and treatment, testing, or vaccines from current levels today, since they are included in your baseline. We included no adjustment going forward for additional costs. We're assuming what you have in your baseline today of your claims It's your typical medical and pharmacy and dental claims. And then you already have the fact that you have your COVID treatment, testing, and vaccine charges in today. And then we are not assuming a huge uptick from those current levels. So there's no COVID adjustment going forward. And really it goes back to the fact that we're expecting it to happen as future COVID-19 waves, similar to what we're seeing with the cold and flu seasons. And then at the same time with the deferred care, we're not including any additional bump up for deferred care coming back into the system. We're assuming what you have in the most 12 months and then trend it going forward. As we talked about the trend levels going forward for the next plan year, we're using medical claims trend of 5.4% and 6.7% for pharmacy. So closer to your historical averages prior to the COVID experience. As we've talked about the US inflation, we would normally recommend about a 1% increase in healthcare trend just due to that inflation and what we may be seeing in the next 1 to 2 years. But at this point, we did not include it into your projections. We heard you all loud and clear that you want to be, you want a 50-50 shot of, isn't it board policy of trend levels, that you want us to assume what we think will actually come in without trying to build in extra conservatism or without being overly aggressive, but where we think claims will come in at. For plan design changes, again, we did include that 2.3%, but that's all funded through the differential cash. So that's so that would not increase your rates additionally. And then, of course, with all the procurements your staff has done over the last 12 months, those are all incorporated, whether it's the PBM contract, life insurance, HRA, HSA, transparency, and telemedicine. We used all the most current information that we could. And then as a result, the contributions are going to increase for the state in aggregate about 5.8%. And to Executive Officer Rich's comment, it does include an additional subsidy of about $3 million to limit that increase for the state active and retiree premiums. It was not applied to the non-states just since their experience did not have an overall increase. So with that, are there any questions or concerns or discussion items for me?
Seeing none, I think now I will open it up to board member questions, comments, unless any of the actuaries or the PEB staff has anything more to add. I see Ms. Woodward with her hand up. Please go ahead.
Thank you, Chair Fried. I just want to come at this a little bit from the standpoint of the state employee and the people that I've spoken to in my own personal experience. Personally, I have the EPO program, and I did notice that it's quite a bump for the EPO and probably HMO, but only a couple of dollars, it looks like, for the other PPO programs. With the fact that our pay has not increased and in many cases has decreased with the furloughs, the fact that we're only getting a 1% raise when in July when inflation is at nearly 8%. The fact that while I'm very appreciative, and I think everybody is, of the coverage we do have, many of those costs have been moved to the employee side. So it's difficult many times to use insurance. You can afford to go to the doctor, but you can't afford to use the insurance coverage we have because you can't afford what they've prescribed for you. If you want to have, an MRI, or if you need to have an MRI, not just want to have one, but need one, or any of those things. I'm actually a cancer survivor, so I look at those. I've got my share of medical debt from things that have not been covered by insurance. I would like to know if there's any possibility of upping what we're using with reserves to cover a little bit more of that raise in policy. I get the increase that's needed. It happens every single year. But is there in this year's case a possibility maybe to use a little bit more of the reserves to make it a little bit easier? I know that people who are at a lower grade than I am just simply can't afford to do anything with their insurance. I can do some things, but there's a lot of treatment I put off because I can't afford it either. So that would just be, myself putting that out there on behalf of myself and every other employee who's in the same position that I'm in. So just to put that out there.
So this is Laura Rich for the record. Typically, historically, PEB has not come with options for rates because, as I said, it's a math equation. It's not something that we just develop ourselves. And in the last couple of years, that hasn't been the situation, just because we've made policy decisions and things like that that do affect the rates. If you do this, then this, right? And so that is why I know last year, possibly the year before that, we had options, but typically we do not present options, and there's a reason for that. We have no wiggle room when it comes to the determination of rates and loading those in. So we have a timeline. We cannot have the rates discussion until late March, because we need the experience to be able to see what's going to happen and to be able to build that into the rates and take that information into the assumptions that are used. So we can't have that discussion until March. Then at that point, we've only got weeks to take those rates, put them into all the plan documents, all the open enrollment material. We load them into the enrollment and eligibility system. They've got to be then tested by staff. So there's very limited time. And on top of that, we're working with, obviously, with the decision that was just made with the new eligibility and enrollment system vendor. So we have very limited time to be able to come back to the board and say, okay, here's a new option. So that's the first piece of it. The second piece of it is that the excess has all been earmarked at this point, the projected excess. We can't use money we don't have. And so there's an inability for staff to say, okay, we're going to take this excess that's already been earmarked for the next 2 years for plan design enhancements, and instead we are going to apply it to rates, right? It's one or the other. And so that has, all of it has been earmarked at this point. And so there is no additional monies. The third point I'm going to make is that, and Member Woodward, you're new, and so you probably haven't heard this before, but if rates are at, let's say that they're supposed to be, they're at 45 right now, let's say it's $45 today, and the increases are supposed to bring it to $55. But instead we buy that money down, or we use the excess to buy it down, back down to 45. So there's no increase. Okay, so we have that money, it's been used, we use it to spend down. Next year when we do rates, we're starting at 55, right? And let's say we need to do the same and raise it to 65. So people are used to paying $45. And 2 years from now, when we don't have potentially excess to apply to it, Now we have to double that whammy. And now instead of a $10 increase, they're getting a $20 increase. That is the potential risk that we face by using one-time money to buy down rates. And so it's definitely something that we don't like to do. And the more that you use it to buy down rates, the riskier it becomes down the road should trend and experience increase. And given the inflationary factors that we're potentially facing, especially in healthcare, I don't see healthcare getting less expensive moving forward. It's only going to get more expensive. And so rates are not likely to come down. They're likely to go up. And that's not just with PEB, but with every other insurer in the nation.
So if I could just follow up with that, I do understand all of that. I just think that we have to remember that what good is your insurance if you can't afford to use it? And so we do have to keep employees in mind, because that's what we're here for, is to decide how we're going to take care of our employees. And frankly, the state isn't taking care of our employees. They're not paying enough. And the governor's office, they know this. Dwayne Young said this in a PEB meeting 1 or 2 times ago. They realize pay is woefully under what everybody else is getting, and our benefits are getting horrible and very costly. I worked in healthcare many, many years. I know healthcare costs go up and up and up. They never go backwards. They only go up. And it's very difficult. But like I said, I think at the same time, we just need to consider who we're representing and what, we have to do the best we can. And sometimes those are really hard decisions. I know that too. But we have to remember that for people who can't even afford to use their insurance, then it's not even a benefit. You're paying for something that's worthless to them because it's a catastrophic plan then, and not, anything else. So the state needs to get with the program and invest some more money in the benefits. And it's not like the excess. It's the state saying, here, we're going to contribute to this because we care about our employees who are working really hard for us, because we are all the ones doing the work, not the figurehead. It's the worker bees doing the work of the state. So those are who are represented when we're talking about benefits. People who make a lot of money could care less. They pay their bills, their medical bills without a thought. But the regular employee says, you know what, I can't afford to even work for the state anymore because they don't pay me enough to cover what the benefits are for healthcare. So I guess bottom line is I do really understand the process and the hard decisions that have to be made. I just wanted to put that out there and remind all of us that we're talking about the decisions that affect real people who don't have the money to even use it.
Okay, I think I'm going to go to, I believe Michelle Kelly had her hand up before Betsy Ayala. So,
thanks, Chair Freed. So I guess my question is for Executive Officer Rich. In your kind of preamble, I guess you talked about all the reasons why it's bad to buy down premium, and I should caveat this that obviously there's a closed amount of money, and it comes into either plan design or it comes into rates. We try to balance the needs of both a lower rate and a higher quality of benefit. But from what I was hearing from you, Executive Officer Rich, you don't actually believe in this buy down that is being proposed today because of all of the reasons why, including, rate shock in a couple of years when we don't have the money. In addition, during our last board meeting when we were talking about plan design, you and your team were extremely concerned about spending any more of the excess, putting it into the plan design, like a few of the board members had requested, because we needed this. And now, so now for me, hearing that the agency is recommending that we buy down these rates is kind of contradictory to me. And as I say, there's no good decisions. It's not going to change how much money is spent on benefits. But I just wonder, where did that come from? Because I don't think it was referenced at the last meeting, and suddenly we're spending that extra money.
Well, Rich, for the record, it's not that I'm against the buy down of rates. I want to emphasize that when we do this, we need to be very cognizant of the risk that we are facing moving forward. Now, the decision to buy down or to use that excess to buy down rates was made as basically it's staff's way of meeting the goals of this administration. So the administration had no appetite to see significant increases in premiums. In that initial rate table that we received from Aon had very significant increases. I mean, the one rate I remember is the employee only, so the cheapest, the least expensive rate for the least expensive plan, and that is the CDHP employee only. The rate today is somewhere around $44. It was going to be somewhere around $71. That's almost a doubling of rates, right? That was not something that we were going to be able to do. And so that is where we worked with Aon to ensure that we meet the administration's goal of not increasing rates substantially. So that's really where it came from, is, we tried to get to as close as we could without doing anything drastic to align with the goals of the administration.
Thank you. Just a quick follow-up, sorry.
Sure.
Just to close the loop, and then I'll. So has the state-based subsidy increased then, or is that also being subsidised by the excess amounts, which is mostly employee premiums, right? I mean.
Correct. So Laura Rich, for the record. So that's the problem that we have at PEB, is that second year, right? So the subsidy is set in our budget. That's legislatively set. So that was determined 2 years ago in our budget, and that was something that is that we cannot change. So we don't have the ability, if trend is more than what was budgeted for, we do not have the ability in the second year to ask for more subsidy dollars. That's a set amount, and that's a dollar amount that's set in our budget. So if there are trend increases in that second year, as there are today, all of that has to get absorbed by the employee. And that is one of the problems that moving forward we are discussing with the governor's finance office and the governor's office, because it's something that, especially with healthcare, not being able to have that safety net for the second year is very difficult, because all of those increases end up on the employee. And that is the only mechanism we have, other than, so we either bring in more revenue or we cut benefits. That is the only mechanism, minus, given the fact that the subsidy is set.
So I'll go with member Aiello.
Okay, so what I'd like to maybe have you explain a little bit more is the actual rate grid on page 4. And I think what it's saying here, and I'm going to say a couple things I thought I heard. So the 3 million would be in the excess subsidy column, is that correct? Okay. We added back some design features paid for by the 26. So that's the design spend down, because we added back features, but the cost of those features show in the rate, and then the design spend down is because we pulled some reserves to do that. So then when we're looking at non-state active employees, because they get the new design change too, but there's no design spend down or excess subsidy because they aren't funded by the state funding system. Or maybe you can explain this grid. You might have in the past, but if you could re-explain it, I'd appreciate it a little bit.
So this is Laura Rich for the record. The non-state group is a much smaller group. And so it's a much more volatile group. You can see it swing one way or the other every year, much more so than the state actives, right? And state retirees. In this plan year, there was no trend for that group. And so it doesn't make sense when they're not seeing the increases that the other groups are seeing, right? It doesn't make sense to lower rates for them. It would, so that lower them even more by creating applying the excess to the to that rate. Because again, what you're doing is creating a situation where next year, if you're giving them artificially low rates, then next year you're having to double those increases, and so it creates a shock. So you don't want to do that. So the excess was not applied to that group because it was not necessary. It would have reduced rates overall artificially.
So then what you're saying is that group's rates are the same as they were this last year, but they still did get the design change enhancements back. So, okay, so that group didn't change, but the non-state retirees did get that because they have some subsidies from the state, I guess, through the state.
So I'll go to member Verducci.
Thank you, Chair Free. Tom Verducci for the record. I just had a question on the different groups, what the methodology is, why we have some going up higher proportionately than other groups. And I'm trying to just figure out the rationale why it just doesn't go up proportionally within the same groups. And also, can that cause a migration during the open enrollment?
Laura Rich for the record. So the methodology that was applied is the methodology that is a board approved policy. And that was explained in the prior, actually, it was in this report. It was in this report where it's so you see looking at it right here. In step 4, the tiering, right? So participant and participant plus spouse, right? So this is the board approved. It's on page 2 of this report. It's the board approved methodology.
Okay, other questions? Mr. Barnes? Got to unmute yourself.
Okay, sorry about that. Jim Barnes for the record. The past 12 months include both Delta and Omicron waves, and I was wondering if that could cause an overestimate if COVID recedes in the future.
Colleen, do you want to take this one?
Colleen Huber for the record. So it is, to your point, the Omicron and the Delta waves are included in the baseline. At this point, we are expecting continued COVID claims for treatments and then the impact of long COVID, but at this more like along historical averages. We're not including any additional costs for other waves that we may see. We realize that the waves are already included in the underlying baseline claims experience. We did not net them out because we're still expecting to see some type of COVID waves in the future, as well as the cost of long COVID. And then, of course, again, if members put off certain preventative screenings or services, you may see an uptick in other conditions such as cancer, et cetera. So we didn't net out the COVID claims because we're expecting some COVID claims to continue into the future, including other treatments for long COVID, and then for preventative services and any type of deferral of care that they did not get, that we may continue to see those claims experience occurring in the future. But we did not include additional costs either to account for any additional costs for continual testing, vaccines, treatments. We thought it would look more like the last 12 months versus other time periods. Does that help?
Yes, thank you.
Member Kelly.
Thank you, Chair Freed. I just wanted to have one other clarification point I was hoping to get from staff. That is, when I look at the grid you put together before we get to the full rates, but kind of where it talks about the dollar increase, the percentage increase, and the enrollment. I just want can you clarify for me, or for the record, really? So we're talking about, depending on the plan, the dollar amount or the percentage is small, like for the CDHP, the dollar amount is smaller than for the low deductible and for the EPO plan. That's a consequence, in my mind, of the fact that the more expensive plans cover or provide a fixed fee for services at time when people are getting them, versus the CDHP that's only going to see employee only a 233 increase. Those participants are going to obviously continue to pay most of their expenses until they hit the deductible, and up to the maximum out of pocket. So is that why we see an increase of 233 on the CDHP employee only versus, larger increases for the low deductible and the EPO? If you could just talk to that a bit.
This is Colleen Huber for the, okay. I was going to say, it may help also, Member Kelly, to look at that next page 4. One thing that you'll notice is the base subsidy in the column is the same across all of the plans. So for example, for employee only, it's at $605.16. And then the next column, again, is the plan design. It's in the same range, but it's a slightly different depending on the different elements of the plan design. But then you'll also notice that the excess subsidy, so this is the spend down to help lower the contributions, is the same across all of the plans. And then to that point, that is why the subsidy altogether is the same across all the plans, but then the cost share to the member or the contribution to the member may look slightly different depending on which plan option they choose. Does that make sense?
Yes, it does. Thank you.
I have a question. This is Hra File, but isn't this a function of boards, policies, and procedures about percentage of the total premium that the subsidy is intended to cover? Because, in the CDHP, the participant share of the total premium is 7%. In other words, 93% of the rate is covered by the subsidies. For the copay plan, 90% of the total rate is covered by subsidies or excess reserves. I'm using that term together. And then on the EPO HMO, it's 79% of total premium is covered by subsidies. You know, so now I got baffled by the share of design spend down and excess subsidies. I mean, this should be assigned based on previously established subsidy percentage, right?
So Laura Rich for the record. So if you recall, the board made the board decision to apply subsidy equally, regardless of plan. So we did that. Oh gosh, I can't remember what it was. It was last year. It was last plan year. And so that the percentages no longer apply because you're giving the same amount per plan. And then it at that point, PEB doesn't care what plan, right? We're subsidizing each plan equally, and the employee is paying the difference between what that plan really costs and the subsidy that the state is willing to give to for any plan in particular.
Okay, yeah, I think this might have been in the January 2021 board policies and procedures update, perhaps. Okay. All right, thanks. Okay, I'm not seeing any other questions or comments. Okay, board members, what's your sense of this nice rate table we've got here for 23?
Tom Verducci for the record. What are our choices here? I don't see the staff recommendation here. We have the rates here in the grids, but what would be the available options here?
I believe, Mr. Verducci, that the staff recommendation is to approve the rate table as presented on page 4 of the staff report.
So we have one table in front of us, and I believe that's the only option that we do see here. I know that these rates have to be done so open enrollment happens. Is that correct?
This is Betsy. Is it my understanding that the rates we're seeing now was based on our decisions from last fall when we couldn't really see rates because the trends weren't in as far, so we had some potential rate information without the trends being fully in. And I think that because inflation wasn't quite the way it's been in the last couple little bit, and although you didn't include inflation in the rate, so I have to back that out. From what I understood, we aren't including inflation in the rates, but the rates might be higher, but it was based on our adding back things to the plan that had been removed. And so then costing out the plans with the added back that we asked this fall. And there's kind of a disconnect because we don't really always know what our add backs are going to cost. From what I'm thinking, maybe that's it, but
that is correct. So, right, the board has already taken the decision to spend down $26 million, correct me if I'm wrong, $26 million of our excess cash to restore the plan design to very nearly what it was prior to the pandemic for FY 23, 24, and 25. In other words, the plan design won't change, which I think is good because it gives members some stability about what their deductibles and out-of-pocket max is. And so that's the design spend down column you see on page 4. And then in order to further constrain rate growth, because you're right, member Ayala, this is not the wider, 7.5% inflation kind of numbers we've seen recently. This is just plain old, correct me if I'm wrong, Ms. Huber, plain old medical and pharmaceutical trend that happens every year, which is why rates go up every year, right? And so that's what you're looking at. You're looking at the combination of enriching plan design for the first of the next 3 years and constraining rate growth just to make life a little bit easier for the participants.
So in other words, it's the cost of what we decided we wanted to buy in the fall.
Yes. And, I don't think this is too bad, honestly. If you look at the participant premiums for just employee only, because that's the vast majority of our participants, remember Kelly is right. It's going up. If you're on the CDHP, it's going up $2. It's going up $4 and some if you're on the copay. And yeah, the EPO and HMO is really where I think you see the pinch. It's the 140 some to 161. So yeah, we're always going to face this increasing medical trend, and particularly our pharmaceutical trend goes up every year. We've had in some recent plan years double-digit pharmaceutical trend growth, and we're not really budgeted for that. So I'm supportive of this rate table. I have to say, I don't, going back to, I just got corrected on the board of policies and procedures, but I'll tell you what's in the board policies and procedures is that the board doesn't use one-time money for ongoing costs. Rates are an ongoing cost, and we're using $3 million, the last bit of excess reserve we have, to constrain rate growth for participants. I don't feel comfortable with that. I understand why we need to do it because, Member Woodward is right. Most of the state employees are getting a 1% COLA in FY23. That's not very much at all. So, but I'm nervous that this may boomerang back on the board if we get bad medical trend year or bad pharmaceutical trend year, and then we have to raise rates by much more than $2 or $4. So anyway, I'm supportive with reservations.
Just real
go ahead, Betsy.
based on what you just said, though, at least next year is a legislative session and people can go and cry at the legislature, I would maybe guess, hopefully. But for this year, I know we all went through that we wanted the plan to move back closer to where it had been. So from the cuts.
Member Corin.
I was just going to make a motion to move forward with the plan year 23 rates that are being presented.
Okay, thank you.
Ms. Leslie,
I'll second.
Okay, I'll give it to Ms. Biddleston. Thank you, though. All right, you've heard the motion to accept the rate table as presented. All in favor, say aye.
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 Any opposed, say nay.
Nay.
Okay, thank you. I'll record Ms. Woodward as voting no. Motion carries. With that, I think we'll go to agenda item 11, public comment. And again, I'll turn it back to PEB staff.
Okay, one moment, please. As a reminder, Zoom is used for public comment only. This meeting is streaming live on YouTube if you want to just listen into the PEB board meeting. The YouTube link is located on the agenda. For those who have joined for public comment, your name or last four digits.
Just a minute, Remy.
Oh, Janelle, or Ms. Woodward, you're still mic is still live, sorry. For those who have joined for public comment, your name or last four digits of the phone number will be announced. You'll be advised that you've been unmuted. As a reminder for those on the phone, please press *6 to unmute and please slowly state and spell your name for the record and then proceed with your comments. Speak with the last name Irvin. You have permission to speak. Please unmute your mic and slowly state and spell your name for the record.
Hello, this is Kent Irvin. Can you hear me?
Yes, we can.
Kent Irvin, K-E-N-T-E-R-V-I-N, State President, Nevada Faculty Alliance. I'd like to thank the board members for going through a lot of important issues today. Would like to reiterate that the master plan documents really do need to be cleaned up and made more understandable for participants. We appreciate that the vaccination surcharges have been rescinded. On the rates, I just need to put on the record a few things. Those excess reserves are excess, differential cash if you want to use the euphemism, but it's excess reserves. That's money that wasn't spent on benefits in the last year or 2 years by participants. It belongs to participants. And so putting it back into rates to stabilize employee premiums is perfectly appropriate. As far as the state contributions, the employer contributions, for FY 2023, it's $755 per employee per month. That's actually less than it was in FY 2020 when it was $761. And the only reason, and one of the reasons we have, well, there are several reasons we do have excess reserves. It's money that wasn't spent by participants because of COVID claims suppression, as well as the fact that federal funds were used for a lot of the COVID claims and other factors over the last 2 years. But it's participants' money. It's not future participants' money. It's past participants' money. And so it's entirely appropriate to use it for rate stabilization. In fact, the catastrophic reserves used to be called the rate stabilization reserves until that name was changed. But it hasn't been dipped into for the last 12 years of the consumer-driven health plan. So, and there was a statement made that this $3 million using excess reserves to stabilize rates is the last dollar of excess reserves. That's not on the record. Excess reserves went up from the September budget report to the ones that for end of December that's in the consent agenda today. Projections are all over the place. I don't really know how those are done or what they mean, but the actual dollar amount of excess reserves went up in the last quarter. It's currently at $35 or $38 million compared with the $26 million that you've reserved over 3 years, I think, for the plan design remediations. And now just $3 million of that is being used to stabilize rates. So I just need to put those things on the record that to counter various statements that were made about this being one-time money. It's one-time money that seems to recur every year, as it has done for the last dozen years because of the overly conservative projections. Thank you.
Thank you. Will the caller with the last four digits of 1601 please slowly state and spell your name for the record and press *6 to unmute. Caller with the last four digits 1601, you have been unmuted. Please press *6 and slowly spell your name. The person with the last name Minakuchi, you have been you have permission to speak, please slowly spell and state your name for the record. If you wish to make public comment. And the person with the last name Fulton, please unmute. You have permission to speak. Please slowly state and spell your name for the record. Madam Chair, that is all we have for public comment.
Okay, thank you very much. With that, we've finished our business for today, and it is 2:10 p.m. and I will adjourn the meeting. Thank you, everybody, for your participation and dedication.
Thank you.